that you're all here. I want to welcome you all to our Generation Hope Conference. This is a case of second time lucky for us. As you know, we planned this for World Suicide Prevention Day, and it coincided, unfortunately, with the Queen's funeral. So it is really great to finally see this day. I chose youth suicide prevention as the theme for our first face-to-face big event as mental health champion. Young people's mental health. Following her seminal Still Waiting study of mental health services and young people's views on those services, she highlighted the lack of data on young people's mental health. And then we had the Northern Ireland Youth Prevalence Study, and it really is an amazing result. It's an amazing source of data on that important topic. So this study gives a clearer picture of the situation here. 1 in 8 of our young people have a probable mental illness. That's at least 2 or 3 children in every classroom. And for some conditions, rates were higher in most deprived areas. But in terms of suicide behaviour, the situation is extremely worrying. 1 in 10 11 to 19-year-olds report self-harm behaviour, and close to 1 in 8 report thinking about or attempting suicide. Again, that's a couple of children in every classroom thinking that their life might not be worth living at that stage of their life. That is truly shocking for me. The rates of self-harm were higher in girls, 13% compared to 5.5% for boys. And girls were also much more likely to have suicidal thoughts or attempts, 14% versus 10%. Almost a quarter, 22.7% of girls aged 16 to 19 years reported suicidal thoughts or attempts. That's a quarter of that age group in girls. And the pattern was not associated with area level deprivation. So it tells you something there about the pressure that our young people are under, even the ones who arguably have privilege, who don't live in those deprived areas. And that's where much of the focus of the discussion often is. In our recent study of students in Ulster University and ATU Donegal, 28% of the students reported suicidal ideation in the year prior to university. Again, that's a shocking statistic. The extent of suicidal suffering in our young people is huge. It's significant at a time when they should be enjoying life and flourishing in education and working to achieve their goals, they're having these thoughts. And it's getting in the way of their achievements. And of course, there are also the deaths. Each year from 2018 to 2021, there were 12, 14, 16, 18 suicides registered in young people under the age of 20. Suicide and suicidal behaviour are so very, very complex. Much of the conversation is dominated by mental health, and there is a need for improved mental health services generally to help address this. However, a focus on mental health is only part of the picture. Suicide prevention research has shown us that suicidal thoughts and behaviour can increase when a person has completed treatment or when they're discharged from hospital. The Children's Commissioner's research showed how just under half of young people who had completed CAMS treatment felt that they had not benefited. So that, again, is really, really worrying. Furthermore, we now have more evidence about the biological factors that influence suicidal behaviour, and the data on suicidal behaviour in people who do not have a mental illness or who have a mild mental illness. We know when we listen to young people that self-harm is often a way of staying alive, of coping with unbearable pain, but it can also increase the risk of suicide. We also know more about how the messages we absorb from the media and social media and information about who died and how they died, how that can impact on how we respond to crisis. Suicide prevention is complex, and it can even be counterintuitive. There are many, many risk factors associated with suicide in young people, and today's conference focuses on a few areas which I felt it was really important that everyone knows about. I really wanted you to hear from young people themselves, first and foremost, and learn about what a good youth-led mental health suicide prevention crisis service looks like. We need to listen to young people, and they will show us how to do this well. Our other keynote speakers will talk about what the research tells us about what actually works in services and in schools. And we have breakout sessions on very, very important issues relevant to suicidal behaviour in young people. Mental health and other services, schools and communities, suicide prevention in the LGBT community, and postvention. How we can help people who have suffered a suicide loss. And of course, why the safe discussion of suicide is important and what that might look like. I hope you find today interesting and useful. I have selected speakers really carefully, and they have really important messages for you today. They're experts in the field and they know what they're talking about. And they are also really good people who really care about this area. So I am so grateful that they've given their time to be here. It is important that we talk about suicide, but today there will be a lot of talk about suicide. And the research shows us that whilst talking is good, so that people get help that they need, it can leave people feeling a bit low. If you've lost someone to suicide, you might feel despair. If you've tried to access services, or if you're a service provider swamped with high numbers of people in crisis, the interventions and strategies that we're talking about today can feel like they're a million miles away. And we continue to have so many deaths, so hope might be hard for you to find today. So please exercise self-care. Take a break if it's too intense. Chat to the volunteers from Samaritans or Lifeline. They're knocking about. There's leaflets. Contact them. Talk about this stuff. They're there. Or give the groups a call later if it brings up anything for you in the coming days. It can be easy to feel despondent in Northern Ireland right now. I have felt like that too. But I'm so heartened by the amazing work that is happening in our communities and across our services, and how the research advances are starting to show real benefits. One of the things I'm trying to do today is shape a conversation around this issue. Our Protect Life 2 suicide prevention strategy is coming to an end in 2024, and decisions now need to be made about what to focus on in the future in terms of suicide prevention. The work will not stop, but I know that the ideas and discussions today will help each of us as we move forward to understand, to support, and to keep that hope alive. So thank you so much for being here, and I'm going to pass you over now to Tara, who'll tell you a wee bit more about what we have ahead today. Thank you.
Siobhan, thanks so much. Definitely echo the comments there made about feeling kind of overwhelmed by some of the discussions today. There are people right around here, so look after yourselves and the people next to you, and just keep an eye out for each and every one of us. Next up, we're delighted to have Professor Nav Kapoor here. He's Professor of Psychiatry and Population Health at the University of Manchester. And suicide and self-harm in young people obviously have been major concerns in many countries for many years. However, the radically different health and societal context today has changed the prevention challenge. And in this talk, Nav will draw on health service and wider research from the UK and internationally to describe how we might best improve care, and obviously the ultimate goal is to save lives. So Professor Nav Kapoor, welcome.
So as usual, I'm causing trouble. My presentation won't work with that, with the original laptop. So they're going to replace the laptop. I'll keep away from that microphone. Otherwise, actually, if I see you falling asleep, I'll kind of wander over there. I'll soon wake you up. I'm really, really delighted to be here. Really pleased to be here. Thanks so much to Siobhan for all the work you do and the invitation to speak. I'm going to talk about I'm going to talk about suicide and self-harm in young people, and I'm probably only going to try and use half my time, so I'll probably speak for about half an hour or so, and hopefully there'll be lots of questions from you guys. So think of questions as we go through. If you disagree with me, I think that's really great. You know, let's have a conversation. But what I'm going to aim to do is just speak for half my time. Okay, so here's an outline of my talk. I'll start with a bit of data. So you've heard some of the statistics, some of the local statistics from Siobhan, but I'll give you some of the international data and some of the UK-wide data. Now, the thing about statistics and the thing about data is in our unit, and we deal with data all the time, we never ever forget that behind the big numbers, there's an individual person with a family, with friends, with others left behind. So you'll see some big numbers, but I always ask you to remember that they're individuals. I'll then move on to what works, what are the kinds of things that the research evidence tell us works, and then talk a little bit about the current and future challenges and how we might meet them. Let's start with a bit of data. So let's take you back kind of 10 years or so. Everyone was saying to me, Nav, self-harm in young people, it's going up, isn't it? And I was saying, well, look, I'm not so sure. I think we're more aware of self-harm. We're better at recording it. And that's probably what it's about. It's an ascertainment issue. We're getting better at identifying it. One of the great things about doing research, one of the sobering things about doing research, is you get to prove yourself wrong, okay? And this is what we did. This is a paper from a medical journal, the BMJ, where we looked at self-harm across the UK from a kind of primary care perspective, from a GP perspective. And what we found was in boys, hopefully this is working, there we go, in boys, rates of self-harm over time were pretty flat. In girls, in the younger age groups and the older age groups, the rates were flat. But in 13 to 16-year-old girls, rates went up about 60 to 70%. Now, that can't be better recording, because if it was better recording, it would be going up in all of them. So the question is, what's going on? And so, it's about the pressures in perhaps young people's lives. It's about education, perhaps their economic factors. Social media is something that's always talked about, and I'll come back to. But I was looking at this and puzzled, and my daughter, my middle daughter, who was between 13 and 16 years old at the time, looked over my shoulder, and she said, I don't know what this is about, economy, other things. She said, you just don't get it, do you, Dad? I said, I've been at this for 25 years. I think I do get it, actually. She said, no, you just don't get it, do you? Yeah, it can be all those things you're talking about. But one of the things that's happened is, you've spent your life dealing with stigma. You've spent your time trying to destigmatise self-harm, trying to destigmatise suicide, haven't you? I said, yeah, and I think that's a good thing. And she said, yeah, but sometimes we have to be careful that destigmatisation doesn't become... She's 14 at this time, by the way. She's saying destigmatisation doesn't become normalisation. She was talking about, amongst some of her friends, there was a culture where self-harm was almost a normalised way of coping. So yes, all those other things, but also, wider cultural factors. And that, for me, is a real lesson that actually it isn't people like me necessarily that should be talking about suicide prevention and interventions for self-harm in young people. We need to ask young people themselves, and I'm so glad later in the day we're going to have a chance to hear from them. OK, there are some other really important things from this paper. The first is something called the inverse care law. So what we found was that young people from the most deprived communities got the least access to care. So the groups who you might think have the most needs, getting the least access to care. And the other thing about self-harm we know, of course, from the lots of literature, is unfortunately it is associated with a suicide risk, a risk of suicide. So sometimes it's dismissed as a not serious behaviour. That's not right. It needs to be taken seriously. And in this study, the risk of suicide was elevated about 17 times. That study's been updated by one of our PhD students, Lukasz Sobolski, and we're seeing rates rise now in the older age groups and the younger age groups too. So rises in self-harm across the board. And that's self-harm that general practitioners get to know about. As everyone in this audience knows, sometimes self-harm doesn't come to the attention of medical services or general practitioners. Sometimes it's hidden. But this is an amazing statistic, really. So this is from we got it there. This is from a kind of census, a national census, the Department of National Censuses in England, but it's actually a survey where they've asked people. And in the 16 to 24-year-old age group, nearly a quarter of girls and young women reported self-harm. So that's an astonishing statistic. That's self-harm. What about suicide? Here's some data from England and Wales. And actually, suicide rates over the past decade or more have kind of been going up. So boys, here are the overall rates. So that's the highest figure for 20 years. And for girls, it's the highest figure in 40 years. That's England and Wales. I know there have been similar concerns here. A real worry. And when self-harm and suicide are going in the same direction, we need to take notice of that. The other thing that, I've talked about people, with suicidal thoughts, suicidal behaviours maybe not come into the care of services, but actually quite a lot of people do. So this was a study again from primary care. 85% of young people who had died by suicide, 3/4 of those who had self-harm, had seen their GP in the previous year. 2/3 of young people who died from suicide had previously self-harmed. So you can see those opportunities to intervene there, opportunities that we mustn't miss. So young people do seek help, and that is an opportunity to intervene. Within the group of young people, obviously, are particular groups that we're a bit worried about. One group are young people from ethnic minorities. And one of the things we found is rates might actually be lower in young people from ethnic minorities, but might be increasing even quicker than those rates I was showing you earlier. But that's not the important bit of the story. The important bit of the story for young people from ethnic minorities is access and aftercare. So we found that young people from ethnic minority groups, compared to young people from white British backgrounds, were less likely to get assessed, less likely to be referred for follow-up or mental health care than their white counterparts. And that's despite the fact that, I've been involved in NICE guidelines for many years. Everyone should get an assessment after self-harm. Young people from ethnic minorities less likely to get an assessment. What's going on there? Obviously, there are other groups we're worried about, young people from LGBT communities and groups, possibly higher rates of self-harm, again, inequities in access to care. So access to care is very important. And one of the things, I need to constantly remind myself about, obviously we're most bothered about, I'm most bothered about what's maybe going on in Manchester, we're most bothered about what's going on in our own countries, but it is a global problem. Suicide and self-harm is a global problem. And in a way, that's particularly so for young people. So that was an article we published a little while ago in one of the journals, but this is data from the World Health Organization. So in high-income countries like ours, this is the age distribution of suicide. So many of you will have heard we're bothered about men, particularly in midlife, also older age groups at the highest highest numbers of suicide deaths. But in low and middle-income countries, there's a disproportionate burden on young people. So it's a global problem, and if you like, young people's suicide prevention is an even bigger problem in low and middle income countries. What am I doing for time? Yeah, okay, brilliant. Let's talk a little bit next about what works from the research evidence. So I help chair guidelines to help services decide how they're going to manage every young person that comes through. How do we come up with guidelines? Well, we look at the research evidence, and the thing we look at most are things called randomised trials, where actually you have experiments almost, where one group of people get one intervention or talking treatment, the other group of people get a different type of intervention, and where you compare them, and you can combine that in these things called systematic reviews. What does the systematic reviews tell us? Not very much, actually. Not very much. So this is a systematic review. We also reviewed it for the NICE guideline. There isn't a whole lot of high-quality evidence on what works for young people after self-harm. So in the NICE guideline, we ended up recommending possibly DBT, a particular type of talking treatment, DBT-A, for young people who repeatedly self-harm. But basically, there's not a huge amount of evidence out there. What about kind of other people, other countries, when they've done reviews? So this is a review from my colleague Joe Robinson in Australia. What did they find? Well, they found some evidence. Brief contact intervention, so contacting young people after self-harm. Psychoeducation combined with screening, so making people more aware of some of the issues might help. And large-scale multimodal interventions where you throw the kitchen sink at you do lots of things all together, and maybe that'll help. But the main thing is there's a paucity of high-quality research. So not enough research. OK, as a researcher, you'll always hear researchers like me saying, we need more research, but not enough research. So what are we going to do? So we've got some indication of what might help, but I think what we then need to do are two things. The first is we need to borrow from the evidence base on what works for adults, OK? So that's things like we know that psychosocial assessments, we know that high-quality assessments after young people present with self-harm, after people present with self-harm, that can prevent people repeating. We know aftercare and psychological interventions, so talking treatments, can reduce self-harm, the risk of repetition, by about half, by about 50%. Safety plans can help. The role of postvention, the role of postvention, I think, is, I was talking to Barry about it just before we started today, that's really in the last 10 to 15 years we've really recognised the central importance of bereavement support and postvention. Not all the kind of prevention priorities are going to quite be the same. So in adults, one of the things we recommend for the treatment of depression, if it's moderate or severe, are tablets. Tablets work to help people with depression. But for young people, the evidence is a bit less clear-cut. So for some young people, yes, tablets are the answer, but it's certainly not first line. What we're saying for young people, talking treatments are always first line for young people with depression. And the other thing is we've got loads of guidance to help us. So looking at the guidance, trying to get that guidance implemented in services, in society. So one thing we can do when there's no evidence is we can borrow, what works for adults. The other thing is being aware of what the specific issues are in young people who, tragically lose their lives to suicide. And that's what we've done in this study. This is a study led by my colleague, Catherine Wadway, back in Manchester. Several hundred young people, unfortunately, who lost their lives to suicide, and she's gone to coroner's records and other sources of data to build up a more detailed picture of the issues in these young people's lives. And none of this is going to surprise you, really. Academic pressures, that I think speaks to the central role of schools and education in suicide prevention in young people. Bereavement support we've already mentioned. The role of early childhood experiences, that's really, really important, something we need to tackle. Family factors, online risk, alcohol and drugs in young people, an important factor. So all of these things, give you clues as to what we might do and how we might intervene. And you can put those things together in a kind of, try and understand what's going on here. So, we call it a kind of cumulative risk. So it's a risk that builds. So some of the young people have traumatic experiences in early life. Well, what might you do about that? You might try and provide better support for young people and their families. Others, later get adversity, other risk behaviours in adolescence, what you're going to do there. Access to mental health services, that's a big problem. I'm not going to kid you that it isn't. Substance misuse and self-harm services are a challenge, but that's the kind of thing you might do. And then there's often a stressful event that precedes, that's an antecedent to the suicide death. So thinking about crisis support, thinking about what we might do in education. So again, we've not got the definitive evidence, but we've got quite a lot of things there from the adult research literature and from what we know about young people who tragically lose their lives. Okay. What I want to talk about now is I want to talk lastly about the current and future challenges. So everyone here probably knows about kind of the role of mainstream media in suicide and self-harm. One of the things we're often worried about is contagion. Okay, so this goes back to, this is an old phenomenon where it's something that's called the Werther effect, after a novel that was published in the 18th century, where the novel featured a young man who was wronged in love and unfortunately took his life. And then throughout Europe, there were a series of similar deaths. It led to the book being banned, and the effect is called the Werther effect. But there's more recent examples. The Netflix series, 13 Reasons Why. The first series of that featured a self-harm, a suicide's death, and featured it prominently. And we know from data that rates of self-injurious behaviour in the States went up after that was aired. So this idea about mainstream media, I think, is there. There are media guidelines to help us. And, it's about not portraying means. It's about not glamorising. There's a whole load of other things. But in a way, what's happened is we've become much more... so that is something we mustn't lose sight of. But in a way, I know, certainly in England and here, social media has become the big thing. Is it social media? What's that doing to our young people's mental health? There are various bits of research on mental health. What about the research on the effects on suicide? So it's a fairly recent systematic review. What did these people find? They found there was an association between social media use, how much you use social media, and suicidal thoughts and behaviours, but small effect sizes. That means it wasn't a strong relationship. Addiction, smartphone addiction, there was a slightly stronger association with suicidal thoughts and behaviours there. Particular types of social media use might have had stronger association with suicidal thoughts and behaviours. But, it wasn't by any means definitive. So, yes, for some young people, social media can be harmful. But there's another part of this, isn't there? There's the positive effects of social media. I know through talking to my kids, through talking to other kids, social media is a kind of positive force. And sometimes we forget about that in the popular discourse. Sometimes it's all about social media being demonised, and we mustn't do that. This is a review again from Jo and her colleagues over in Australia. Just thinking about how apps, how online therapies can be used to improve the lot of young people. So it's a double-edged thing. You've got the social media, might be harmful for young people. On the other hand, you've got how we can use it positively for prevention. And this is interesting. I've told you about young people and suicide. I've showed you data from England and Wales, but it's an international phenomenon. So this was a study done out of Bristol. Priyanka Padmanathan, one of my colleagues, did it out of Bristol. And rates of suicide, in young people going up in Australia, up in Canada, up in recent years in the UK, and up in the United States of America. And what this study examined was they looked to see whether they could find a link between these rates of suicide and social media use. And they didn't find much of a link. What they did find was that rates were going up in high-income countries which had lots of income inequality. So it's back to some of that economic drivers of suicide. So social media use wasn't associated with suicide rates in this international study. You've got to take it with a bit of a pinch of salt. It's an observational study. You're looking at two things, trying to correlate them, but an important potential finding. And of course, young people don't just spend their time on the internet, on social media. There are other things young people do. So this is from that study that Cathy Wadway did, looking at internet use. And, quite a lot of people had used the internet, that's boys and girls, prior to the death. But, it wasn't just all suicide, social media, bullying, communicating intent online. Websites which, may have been kind of pro-suicide websites or seeking informational methods. So people use the internet in different ways. What's the solution to that? Well, one solution is, educating our young people about how you use the web, how to engage with the web, educating parents, educating schools, and I know a lot of that work's ongoing. But part of it maybe legislation, and that's certainly the route we've gone down in the UK, haven't we, with the online safety bill. You know, some content is now illegal, some content is legal but harmful, and you know that may help. Although many people might argue that that legislation hasn't gone far enough. Okay, it hasn't gone far enough. Here's another, it's a kind of past concern, but it's turned into a future one. So back in the early days of 2020, these are the kinds of headlines that were circulating in England. I'm sure you had similar headlines around here. You know, the worry that the COVID pandemic was going to lead to more suicide and deaths, so-called deaths of despair, than deaths from the virus itself. What actually happened? One of my colleagues in Australia said, oh, look, I've got this plan for a great study. We're going to get data from everywhere in the world, and we're going to see what effect COVID had on the rates of suicide. And I said, you can try it, Jane Purkis, my colleague in Melbourne. I don't think it can be done, but I'll help if I can. And of course, 12 months later, she comes out with this great study. 21 countries, timely data. It's a bit patchy, the data, but what's the bottom line? Actually, suicide numbers remained unchanged, or in fact, in many cases, declined during the early part of the pandemic. What's that about? Well, a removal of normal stressors, so school, work, people not going about their lives. People talk a lot about social cohesion in suicide prevention, so this idea that at times of adversity like wars and other things, we all pull together. There was certainly a bit of evidence for that early on, I think. Less social isolation, more supervision, people not on their own, they were supervised more. And the other thing was economic and policy mitigation. So the furlough scheme, which actually, you know, despite what you might think of the overall handling of the pandemic, the furlough scheme here was quite generous, and that might have accounted for it. That's overall, but what about young people? Early on, we got really worried because these data came out. The National Childcare Mortality Database, it's England only, but they try and collect data in real time. So many of you will know for suicide statistics, there's often a bit of a delay because deaths go to the coroner investigates them, they then reach a verdict which then gets coded by your National Statistics Agency. So there's often a delay. But what this mortality database did was collect the data in real time. And what they saw early on was possibly in April and May of 2020, a kind of they were reporting maybe a 30 or 40% increase in child suicide deaths, right? Now, that wasn't statistically significant because overall the numbers were mercifully small. But, we were very worried about that. In fact, when the actual data came out, the official data, probably there wasn't that rise. I mean, there might have been a bit of a rise in April, May, but overall in 2020, there wasn't. So this is the official data now, about 12 months later, that comes out. And this is, if you look at the blue lines, that's persons. These are people dying by suicide, young people dying by suicide in 2020. And it's kind of a little bit lower than kind of previous years. For boys, again, lower than some of the previous years. For girls, I mean, it's very difficult to say because these are kind of quite small numbers, but a little bit higher than 2019, a little bit higher than 2016, but kind of similar. So, an initial worry, maybe, but then overall, when you look at 2020 overall, we weren't too concerned. But there were other things, weren't there? So lots of surveys out there on how young people's mental health was affected disproportionately during the COVID pandemic, and I think that's right. I think it absolutely was. Some interesting data about school closures as well. School closures were associated with better mental health, actually, and when people went back to school, their health kind of worsened, but all in the context of COVID. And then this is data from primary care again, so general practice. Bit of a worry here because all the rates kind of went down in that acute pandemic period, but it's this green line I want you to look at here. This is self-harm rates in young people aged 10 to 17. This gradual increase. And there was a systematic review as well that, again, I mean, a bit of a worry. So overall, no early indications of a rise in suicide in young people, but we know their mental health was very adversely affected, and just this suspicion of rises in self-harm rates. So something we really need to keep an eye on. And just see how I'm doing for time. Yeah, okay. So the other thing is, since the pandemic, there's this new word, permacrisis. It was word of the year last year in one of the dictionaries. We've had a lot going on, haven't we? We've had war in Europe. We've got the ongoing kind of climate change thing that some of our young people, all of us are worried about, but some of our young people are kind of particularly worried about. And then, of course, the economic factors and the cost of living crisis. Recessions, periods of economic uncertainty, they're bad for health, they're bad for mental health, and they're really bad for suicide. So there's some data from the United States. This is from the last recession. Basically, start of the recession in 2007, 2008. This blue line is the excess deaths from suicide in the States, nearly 5,000 excess deaths in this time period. Similar data from all over the world, Europe, England, Wales, everywhere. Similar stories. Recessions hurt people. Now, one of the things economists will tell you is that not all recessions are the same. And this recession, this period of economic uncertainty isn't the same as the previous one. Of course, they're absolutely right. But I think we can learn something from our responses to previous periods of economic downturn. So this is work we're involved with, led by my colleague David Gunnell in Bristol. Some of the things that might kind of help. So, if we're talking about frontline staff who are in contact with vulnerable individuals, help them with some kind of mental health literacy, help those people with mental health literacy. Staff working in mental health services in the NHS, in social services, they need to have advice on where to signpost people. And giving kind of timely funding to some of the debt and other advice agencies. So some of these things still apply. Of course, some of these things aren't in our control. Some of these things are in the control of governments and policy. Appropriate investment, increasing welfare rather than cutting welfare at the times of recession, we know can protect against some of those increases. So we saw rises in the States, but we didn't see rises in Sweden, didn't see rises in Portugal, and they're countries that increased their welfare spending rather than decreased it. I always like a soundbite. This isn't one of mine. This is from David Stuckler in Oxford, making the point that recessions hurt health, can hurt health and mental health, but it's actually the policy response, if you stop investing in people, that kills. So it's the austerity that might be associated with suicide. So we've had COVID, we've had wars, we've had economic recessions. The other thing, of course, is the health service context, which you've already heard about, which was tricky before and is even trickier afterwards. So I know you've had your own issues with waiting lists, etc. Here, just to show you're not alone, here is some data from England. Here, look, this is for child mental health care. A fifth of young people waiting more than 3 months. I mean, come on, quite often these people in crisis, we've really got to do much better. So a health service that was under pressure before COVID, broken by COVID, and now in some areas, really in pieces, and we really need to do our best to pick that up. But where does that leave us? Where that leaves us is, well, we've got these new challenges coming, but the evidence is still the evidence. It's the kinds of things I've talked about, talking treatments, proper assessments, using guidelines. All the evidence is still the evidence. High quality care is still high quality care. And new periods, new strategies offer opportunities. So we're redoing our suicide prevention strategy this year. Your strategy's coming up for renewal in 2024. These are real opportunities to put what we know works into practice. So I think, yes, the prevention context is changing, but we've got real opportunities here. So I've told you a little bit about the data internationally and from England and Wales, spoken a little bit about what works, and talked about some of the current and future challenges. So here are just the take-homes. Self-harm and suicide in young people are global issues. They're going up in many places, but we don't know for certain why that is. Quite a lot of young people do seek help prior to suicide, but remember these inequities in care. Evidence on what works is not great, but we can borrow from what we know in adults as well as looking at the characteristics of young people who die by suicide. And I've talked about some of the current and future challenges: social media, pandemics, economic problems and health service pressures. And the context may change, but the evidence is still the evidence. And the last thing I'd just like to do is thank all the people back in Manchester who do all the hard work. Thank you very much for listening.
Thank you. That was really insightful. We're going to open it to the floor now. You have the opportunity, if you're joining us online, to send questions in. But if you just want to raise your hands, we have roving mics on either side. I mean, this is a great opportunity to ask some questions and get some more on the areas that you're interested in. Here we have our first one.
Thank you. Can you hear okay? Yeah? Okay, thank you very much. That was a wonderful presentation. My name's Ellen from the Samaritans. And I wanted to ask, what part do you think that stigma plays in terms of self-harm and those help-seeking behaviours?
I think it's a really important bit of why some young people don't present, why sometimes it's hidden. But it is this interesting kind of double-edged thing. So I think, stigma, we need to destigmatise attitudes, and it's part of something wider. So it's not just self-harm, it's self-harm, suicide, mental health in general. So definitely we need to destigmatise it. We also all need to destigmatise it, not just amongst the general population, but in services as well. So sometimes, I'm ashamed to say, really, that when young people present to mental health services, when they present to emergency department services, there's still stigma attached. They're blaming attitudes as less than ideal treatment. So we need to destigmatise. We need to destigmatise in society. We need to destigmatise in services as well. We need to kind of demystify a little bit as well. So one of the things we've tried to do in the latest NICE guidelines is to make sure that people know that self-harm's everyone's business. So we've got a bit of stick actually from teachers saying, well, you're not expecting us to be mental health professionals, are you? And I'm absolutely not. But what I am saying is self-harm can present in classrooms, it can present to teachers. You need to understand it a little bit and you need to know what to do. So that's what we are saying. There is this kind of thing that troubles me about this curious double-edged sword that I mentioned right at the beginning that my daughter raised, which is, we need to destigmatise self-harm, but we need to not normalise it. And what we need to, for me, push is the help-seeking behaviour. Now, I know, there's lots of different views of self-harm, and I know lots of young people will tell me that they use it as a coping strategy, and that's okay, but for me, the treatment goal would be then what are alternative coping strategies, not, we carry on with the self-harm. So it's a really interesting area.
Thank you, Ellen.
There's one there, isn't there? Yeah.
Thank you, Colm Gildernew, MLA, and thank you for a very interesting presentation, I have to say. And one of the bits that struck me most powerfully was the slide where you had outlined that recession hurts, austerity kills. And regrettably, I have to say, I think we are seeing that in real time. The impact of austerity is now really crashing onto the beach in a big way. So that's very worrying. I suppose two of my questions would be, first of all, and this concept was raised with me as a result of some very good work done by a group in my own constituency, Niamh Louise, who have raised with me the issue of psychological autopsies. And I'm wondering what your view is and how that can play a role in terms of the evidence. And also the other then concept will be around social prescribing. Is there a role in this particular area for social prescribing?
Yeah, I'll take the social prescribing one first of all. Absolutely. I'm a kind of psychiatrist. I work mostly in mental health services. I've talked mostly from a health or public health perspective, but certainly kind of social prescribing, certainly some of those non-health interventions, I'd broadly call them public health interventions, actually. Plugging people into the right bits, plugging people into the help seeking they need, absolutely. The role of the third sector as well. So some of you will be from charities, I think, in the audience. Absolutely vital, particularly at this time when I'm afraid services are strapped. It shouldn't be viewed as the third sector having to pick up the slack for mental health services, but I think the third sector have a crucial role to play. And sometimes we talked about stigma. People are a bit more willing to seek help from their peers or a third sector organisation than they are from me in the health service. So social prescribing, third sector, absolutely vital. The role of psychological autopsy. So what we mean by that is when a suicide death tragically does occur, when someone has hurt themselves, when that happens, you look in more detail, you try and piece together what happens. That's can be absolutely helpful. And in a way, Kathy Wadway's study, that circle of the kind of factors, and when she studied, several hundred young people, that was a kind of psychological autopsy study. She didn't talk to the families in that study. It was, over 300 deaths, but she looked at, lots of different sources of information. Other studies, of course, have talked to the families. It can be distressing for families, but you can get real insight. So I think it can be a really valuable methodology when you're trying to piece things together. And Siobhan's already mentioned the complexity as well. And I think, the psychological autopsy method can help with that. Great.
Thank you so much for that talk. Really, my question is, I'm Ethan. I do quite a lot of work for suicide prevention, and coming from a background of having special educational needs and being through the care system, you're often maybe falling through the cracks, and there often isn't that a need to rely for support. Like I have experienced a lot that like that missing parcel, that you're maybe referred to a professional, and then they turn around and say to you, oh, there's nothing we can do, we'll pass you to someone else, and you're just then going around that same method over and over again. So it's really just seeing why is that, what's hopes for the future?
That's a great question. There's two things there, I think. The first is about, people that have gone through social care system, kids looked after kids, and also, kids with special educational needs. All of those groups are vulnerable, and we need to be kind of aware of that. The falling through the cracks is really interesting. I think self-harm services, certainly, in England where I work, have been characterised by fragmentation. So it's basically, you go to one service, they say, oh, you don't quite meet our criteria, we'll refer you back to your GP. Get back to your GP, they say, oh, well, we'll refer you to this service. Oh, right, OK, sorry, you're over 18, we can't see you. So it's this. So one of the things I think we try and get across is that self-harm's everyone's business. And we really, really need to get a kind of joined up care pathway. And it's no good mental health services saying self-harm isn't our problem because it's not a diagnosis and it's not serious mental illness. And then, general health services saying, oh, this is a mental health issue, and, people with self-harm falling in the gaps. That's, we can't have that anymore. One of the solutions we've been trying to push in England is liaison psychiatry, so mental health services that bridge the gap between the community and hospital. That seems to help. The other way of plugging gaps is actually the third sector. They're much better at doing that than we are sometimes. Thanks for your question.
Ethan, can I just ask you a follow-up on that? What would you like to see? What do you think as a young person from that perspective? How do you think it should be managed? Do you want to be part of that wider group, or do you think it should be targeted?
Yeah, and it's kind of quite challenging because I know, of course, I do quite a lot of work with like politicians and MLAs and stuff, and they're often willing to listen to you. They're often willing to take on their views when you, of course, mention to them. But then it's often then you forgot about, or you're maybe a consultation or something's drawn up, and they're not actually speaking to young people. It's just an assumption, or it's just, oh yes, we've data here, we've data to prove, maybe within what worked in the last 5 years, but then it's then left, or you're kind of just a number, or you're a tick box exercise, and it's just scary to think. Like I feel I'm 22, but being a suicide survivor and stuff myself, it's just scary because you don't know, especially coming out of the pandemic, what support and what help there is for young people. So it's just goodness knows what will happen next.
Yeah, well, look, thanks for your question. There's lots of people here today. I'm sure that's part of the reason why you're here, is to tie in with lots of different organisations. So, we'll maybe have a chat about that a bit later. Thank you so much for your question. I think there was somebody up here wanted to ask a question. Oh, here, just great. Actually, you could pass it back. Might be easier. But we'll get it round to you. Or pass the mic.
Pass the mic.
That'd be great. Thank you.
Yeah.
Super.
Hiya. I used to work with young people in Liverpool, so I've seen, I suppose, living and growing up in Northern Ireland and them working in Liverpool and coming home again, a big thing that for me seems to come up time and time again is the kind of systemic inequalities here, in terms of our culture, but also how far we are behind in terms of, equality. You brought up stuff there around, if you're from an ethnic minority, and this is in England and other places, but I do think issues like that, LGBTQ issues are another big thing here. But I think, when those kind of messages are coming from a governmental level and we still are really behind in terms of even our mental health services are still very much focused on the, biologic, kind of say it's medication first, and you don't get access as an adult to much else. So when we look at young people, then that's even more difficult. And I'm just wondering, in terms of our local context and addressing some of those more systematic kind of inequalities, is there anything that we could be doing? I know some of it is the legacy of the Troubles, but time's marching on now, and we really need to step up.
Yeah, Nav, I'm going to put that to you, and I'll maybe bring Siobhan in as well. But I don't know about anybody else in the audience. When you saw the figures, we can only dream of having 50% of young people being seen within 4 weeks. That is astonishing. So it just gives you the sense of perspective between what we have here in Northern Ireland. And to be fair to the health service, it's the same with hip replacements. I remember watching a piece on the 10 o'clock news about a woman in England complaining she'd had to wait 6 months. Some people here are lucky to get it within 10 years. So, there's systemic, huge problems. So I would imagine that kind of tied in with people. But first, to answer that question, are there inequalities are there better ways to beat some of those inequalities?
So there's two things about the inequalities. There's the inequalities themselves. So suicide rates, self-harm rates are going to be higher in some of your communities than others. The big one is kind of deprivation. You look at the gradients with deprivation anywhere across the world. If you're living in more deprived circumstances, you're at higher risk. So that's one bit of it. And that is a really difficult bit, because what you're trying to do is level up, sorry to use a political term, but, you're trying to level up. You're trying to get resources into those more deprived communities. There's not always the political will, and that's not always within our power. So that I think that's one really big bit of it. But the other bit is the access to care thing that I was telling you about. I'm puzzled by that. I'm puzzled why, if a young person from an ethnic minority, and that was Manchester data, turns up to my emergency department in Manchester, why aren't they getting an assessment as commonly as the white young person? What is going on there? And I don't want to use words like institutional racism or anything like that, but it's just puzzling. And there's lots of other groups like that. So there's an inequity there in the rates of self-harm and suicide, but then there's an inequity in access, which I think we can do something about more immediately. Yeah. But Siobhan, I don't know if you want to say anything about, inequity and inequalities.
Well, is my mic switched on?
Oh, yeah, can we get that?
Hello.
It should.
Yeah, it's working.
That's now, is it?
That's it.
Super, yeah. No, I mean, in terms of policy, and that's my work now, so I've had to be across this. Who can do what, and how do you get what bits of this done? Reducing inequalities is really about your programme for government. That's about things like welfare, it's about poverty, it's about childcare, it's about all of those issues. And then there's things that you can do within particular government departments. And when we did have a government, our Department of Health developed a mental health strategy. It's not cross-departmental, it's actions that can be done within the Department of Health. And that is where we have the 35 actions around reforming mental health services to create a regional service, including the community and voluntary sector, with a common regional outcomes framework. And of course, that service needs to be equipped to deal with people who have self-harmed. So that is a strategy that I'm banging on constantly about that needs to be implemented. And we have funding in the draft budget for that, but we don't have an executive to sign off that draft budget. So we're going to be entering the next year, if we don't have an executive, without progress again for the third. This is going into the third year. So we're implementing it, we're making the changes, but we need more money and we need a government to sign that bit of it off. But, we do need to tackle structural factors as well, and attitudes, racism, homophobia, all of those things are more prevalent, arguably, here in Northern Ireland than other places. And we are behind the times in terms of our mental health research and the number of trainee psychologists, psychiatrists, and all of those professional groups too. So that's my job, and that's what I'm working at now to try and change things.
Another reason when we don't have government that we do have a mental health champion and commissioners in other departments as well. Just this gentleman here, nice and handy.
Hi, really interesting statistics. So I was just wondering, has anybody looked at the correlation between the increase in public health spending on services? And I thought it was really insightful of your 14-year-old daughter to say removing this stigmatisation but not making it normal. And having worked with young teenagers, and especially young teenage girls, there seems to be an acceptable, almost fashionable at times, peer sort of pressured, acceptable thing to, I'm feeling really bad, I'm feeling worse than you. Long to see the day when celebrities say it's the coolest thing in the world to be happy and content. So that was one thing. Is there an increase between awareness, public health spending money on these things, and the rates? And the other thing is there any sort of research or data on the increase in acceptable use of illicit and prescription drug use? Again, seeing families where young teenagers are indulging with their parents and grandparents. So I was just wondering, so
I'll take the public health, the spend on public health interventions. Is it linked? Is it effective? There's not a huge amount of evidence on that. We did some evidence a while ago where we looked at mental health service changes and the effects on suicide rates. And in spending in 3 areas, or certainly developments in 3 areas, did make a difference to suicide. So crisis care, drugs and alcohol, involving families. When you invested, when those services came, when those services were more in evidence, that reduced suicide rates. The second bit was about awareness of suicide and how the destigmatisation, normalisation. I don't know if there's a whole lot of actual evidence on that, but certainly, some of one of the things people always say is, well, you just need an awareness campaign now. If that's all you need an awareness campaign. That the evidence on awareness campaigns is a bit mixed, and I'm saying if you do have an awareness campaign, the awareness should be the awareness of where to seek help if people are in distress, rather than general awareness of suicide and self-harm. I think it's it is a tricky one. Drugs and alcohol, there's plenty of data linking drugs and alcohol with suicidal behaviour. It's a major risk factor. It's a major risk factor even in young people. I mean, one of the things that's interesting is in young people, rates of alcohol use seem to have gone down in England in recent years. I mean, so it's difficult. Some substances kind of are going up, but the link is certainly there, and it's an important part of any prevention strategy, I think. Thanks.
Yeah, because I know each of those are kind of, they can overlap, but drugs and alcohol was the highest percentage that appeared in your slide there. A couple of others maybe. Oh, just one here. Thank you.
Hi, Nav. Sorry, you touched on it earlier there in regard to our teachers in post-primary, are they able and are they, I suppose, experienced enough to deal with someone who presents with, if they've self-harmed? So my sort of question is all based around, are they also in a position to determine if a child who has erratic behaviour, if a child who is acting out, if a child is, you know, just maybe showing signs of bad behaviour, is there a mechanism within our post-primary education system for our teachers and, I suppose, you know, the mental health teams within our system, are they able to determine the difference between someone who actually has a true mental health illness, or is that child a child who is just a bad egg and just...
Okay, so I'm a bit unusual for a psychiatrist because I don't actually like psychiatric diagnoses very much. And I don't like labels very much. So I think it's one of the problems, actually, with our system where, you know, in order to be accepted into a certain service, you need to have a diagnosis or you need to have a certain problem or you need to be labelled in a certain way. I think one of the things we've tried to do in services, and it might be more of a leap for education, but I don't think it would be, was to focus on needs. So it isn't necessarily about the diagnosis, it isn't necessarily about the label, it's about what might help. And I know that might be even more difficult in an educational context, but you know, that's what I think we need to be thinking about. It isn't about, you know, this is illness, this isn't. I think these are needs. How can we best help them? Does that answer your question? Kind of.
I suppose, is it from your point of view that it's very difficult for teachers to take that on as well as everything else? So, you know, how do you make that assessment, and are you do you feel, are you a teacher yourself?
I'm not a teacher, no. But I have experience. I've lost a sister, and I think for me personally, you know, at her post-primary level, when she was, you know, 11, 12, yeah. You know, for me at that point, and for us as a family at that point, her mental health issues should have been identified at that point within the education system, yeah. And they weren't.
Yeah.
And that's huge.
So there I'd be talking, it wouldn't be a diagnosis, it would be, you know, the mental health needs should have been identified. I mean, one of the things they've got a big push on, and Siobhan can tell us whether it's similar in Northern Ireland, is, you know, having a mental health specialist, so it'll be a nurse, a school nurse, something, in every single school in England. And I wonder if it's similar here, because that, I think, would help. Because I agree the recognition isn't there. But I don't think we need to be concentrating on labels necessarily.
The Department of Education produced a framework for schools around this whole issue of emotional well-being. They didn't call it mental health because that was health. It's a different department. Can't have any of that mixed and stuff. Different, yeah, but funded interestingly through health and education. But this was a whole school approach towards good mental well-being and early intervention and prevention for young people who were at risk or who had difficulties, and then a series of programmes of interventions and getting people to the help that they need. But even in terms of the whole school approach and the school environment, none of the stuff is mandatory in any school. We have a very fragmented education system, and in the New Decade New Approach there's a commitment to a review of education and looking at the different sectors, but right now we can't mandate anything within schools. But there are lots of really strong programmes, including CAMS teams in schools, yeah. And many schools are just doing their own thing. The problem is with the cuts to our budget as a result of the fact we don't have a government and we had a budget from Westminster, means that many schools can't even provide the very, very basic stuff, the paint on the walls and the books for the kids to write in. Never mind even the school meals issue has been a problem here because of the levels of deprivation. So, you know, we're fighting a losing battle, but there are some really excellent initiatives. We have a text and nurse scheme. We have CAMS teams starting in schools. But our teachers feel overwhelmed and they can't cope, and they have difficulty differentiating between behaviour that is just, you know, an energetic child versus a child who's got real mental health problems. And there's still use of restraint and seclusion in our schools, which is completely unacceptable.
It is. But, I mean, the message there is getting that mental health support actually in the schools as kind of part and parcel of it.
Okay, thank you. I'm sorry about your sister, and thank you so much for asking that question. It's really important. We'll take a final one. I think, okay, 2 more. You go first.
about 17, 18 years ago, there were 20 deaths to suicide in North and West Belfast. The majority of them were actually young people. And at the time, families actually came out on the streets to protest. I actually remember the first public protest we had was at a meeting of the Belfast Health and Social Care Trust. They wouldn't allow us into it. You actually covered it, Tara, for the BBC. Yeah. But as a result of that, people through, and it was families bereaved by suicide, going on to the streets, forced the government here to have its first ever suicide strategy, Protect Life. The thing we pushed was, suicide wasn't about health. We needed cross-departmental buy-in. It's also about education. It was all those other government departments buying into it. But by and large, in our communities, the disadvantaged communities, that's where the majority of deaths were. But a lot of that strategy, families helped shape, and a lot of it was about the lack of services. That's what was happening in our communities. People didn't have services to go to. And a lot of new community-based services actually came out of that and have been running for many, many years. But in this last 3 to 4 years, since tendering and commissioning have been brought in by the Department of Health, the majority of those services, their capacity to deliver has been greatly reduced. I know at least 3 in Belfast have closed, and the writing's on the wall for the others. And that, to me, it's in communities that need those services most, where you actually have services that do want to be there, that do want to provide the service. Unfortunately, we can't compete with big businesses. We can't compete with big voluntary organisations who can pay funders, fundraisers, consultants to do tenders for them. We can't compete. And at the minute, services in those communities that need them the most, unfortunately, are closing or having their capacity to deliver greatly reduced.
I'm very sorry to hear that.
Yeah, it's really concerning. Thanks for bringing that up, because it's another one that we can add into the kind of overall points from today. Just this final question then, just one more. I think you had the... We've plenty of time for Q&A later on, so if you do have a burning question, there will be time later. Keep talking, I think it should come up.
It's the blue one. We'll make it work. Well, I'll ask you a question, I can repeat it.
Yeah.
Okay, well, I work with the Secondary Student School Union, and, whenever there's some great statistics, like I think I even saw myself in some of those statistics, whenever, you said that during COVID, whenever schools closures were happening, that there was like a decrease in, children who felt, self-harm and suicide. I really saw myself in those statistics, because I felt like when I came back into school, suddenly I was so overwhelmed with all, the work and the exams and all the rest of that. And, even though I did reach out at that kind of period in time, I feel like, there was long waiting lists, there was not a lot of kind of, the students around my friends, they don't really know, and, even if I ask them, they don't know what to tell me. So, we work a lot, we're doing a lot of kind of reports and trying to see if there's some way that we can put mental health into the curriculum. And I was just wondering if you think that if it was taught as in like, as part of different subjects and how that would look like, if you think that would have an impact?
So the question was, this young person, thank you for your question, was talking about how she saw herself in some of the statistics, particularly coming out of COVID, finding that difficult. I think that's right. A lot of us were quite worried about that, because, suddenly the world's going to go back. You're going to have kind of, pressured services. You're going to have, people kind of progressing at different rates. Suddenly kind of exams are back. Suddenly everything else is back. And it was a difficult time for many young people. So thanks for that. And the question was about, should we be having more mental health? Should we be having more self-harm and suicide kind of awareness, literacy in schools? I think we should. I think it needs someone much cleverer than me to decide exactly what should be in it, and we need to work with teachers, educationalists, what's going to help people. And I know there's some excellent examples already around, but I think that's where it kind of starts. You're absolutely right. But, we need to be aware, a double-edged sword, so increasing awareness, not normalising, I think. That's the thing. Thanks, great question. Thank you.
Thank you. I'm just going to take one final comment from Siobhan on this, because this is really crucial for our community here.
Yeah, I wanted to say that mental health is in the curriculum, and there is an amazing range of resources on websites for teachers to use. Unfortunately, again, the priority in our education system is achievement, and that's defined as the results at GCSE and A level. So all of this just goes to hell whenever it comes to the GCSE year, and that's exactly the year in which we see that surge of self-harm behaviour in our young girls particularly, and an increase in mental health problems and behavioural difficulties generally. And what myself and the Children's Commissioner are calling for is that the whole school approach, that idea of how well can this school address and meet the needs of young people and create an environment where their mental health needs are supported, that we inspect that and that we provide league tables based on that, and that's what we want. And we're calling for it, and it is possible. Other countries can do it, and that's what we need to be moving towards. Thanks.
Brilliant. That can go alongside the league table of A to C star, or A star to
just
C.
Get rid of the...
Well, yeah, there's that too, but I can't imagine they would ever agree to that. Thank you very much.
Thank you.
Really appreciate it. Lovely talk this morning. Really worthwhile. Thank you. Slightly concerned that our next group have just walked off. I just saw them. I've been looking at them, and the whole way through there I thought, well, that'll be really good for the next item, Crisis Cafe. They're going to know about that, all the stuff around young people, education, self-harm, and then they all got up and walked out. So I will perhaps sing a song now for the next few minutes. Hopefully it will not come to that, but they will come around. Oh, thank you. They will come around and talk about the great work that is going on there. And I think there's something to be very enthusiastic about. We talked about this earlier, Siobhan, you know, that next generation. So at the centre of everything you do is young people at the heart of the service, how to develop that service, how to provide that service. So this is a great opportunity to hear what these young people in the Crisis Cafe have been doing, and then what they're putting in place for the next generation. So hopefully I really will not have to sing, and they'll be here now. Yay! Welcome. I'm not going to introduce you all individually. I'm going to let you do that, but thank you so much. Crisis Cafe. So who would like to start? There you go. Willing volunteer.
No. Good morning, everybody. So I'm Louise Quinn, co-founder of Crisis Cafe with my colleague Ronnie Graham, and an initial young advisory group in 2020. So I'm not going to say very much this morning. I'm going to keep it brief and leave enough time to hear from all the young people who have kindly come along today. So Crisis Cafe is a mental health service for young people aged 11 to 18 years, offering a range of early intervention, easily accessible, non-referral, individual, group and peer-based support. The age bracket extends to 23 for those who have accessed the service prior to 18 years. We aim to improve the mental health and wellbeing needs of young people, utilising an innovative, socially creative, safe, warm, welcoming, inclusive environment, a space where positive mental health and wellbeing is promoted. Crisis Cafe are a youth-led service. Young people are the driving force behind our services. We have a highly active and participating young advisory group who co-design and co-lead all programmes, managed and guided by practitioners with skills in mental health and participation. Young people advocate for the voice of young people around the area of mental health to break the stigma and actively lead the youth conversation around mental health and mental health awareness. Grania and I are qualified social workers with over 20 years' experience, each working in the areas of children and young people, child protection, trauma and mental health, with extensive training in risk assessment and therapeutic interventions. Prior to setting up Crisis Cafe, we worked with an initial advisory group every week for approximately 12 months. They designed Crisis Cafe, which at the time consisted of two types of cafes: a crisis drop-in offering one-to-one support and a friendship cafe offering peer support. The model is fluid and responsive to the needs of young people, and they can move between the cafes and services offered as and when needed. This service provides young people with increased accessibility to community-based support within a warm, inviting, non-stigmatising environment, where they can avail of a range of activities and services to improve overall mental wellness. No referral is necessary. Services are accessed via drop-in, or a young person can be signposted from other organisations. The only criteria we have is that the service is for young people. The name Crisis Cafe was chosen by the initial advisory group, as they viewed that in order to reduce stigma, it is important not to shy away from the fact that everyone can struggle and that everyone can be in crisis at some point in their lives. They viewed that a crisis is individual to each person and that it is not necessarily what we as adults or professionals define to be a crisis. At Crisis Cafe, we create environments and relationships that are trauma-informed and trauma-responsive. The relationships we make with young people can and do make a difference. Most therapeutic moments don't take place in one-to-one support, but in the cafe space. Day in, day out, relational moments make a difference. It's not what you know, but how you are. Therapeutic moments create a relationally enriched environment that creates safety. This then opens conversations about how young people feel, which is safe, healthy, supportive and healing. We focus on building relational wealth with young people so they feel safe, valued and cared for. Once they feel safe, supported and regulated, they thrive and flourish. I will finish with a message we received from a parent recently. The Crisis Cafe is such an important place for Newry's youth. They have created an amazing, safe, inclusive, fun space for them to be themselves. Thank you. And we'll have Aoife up next.
Hi, my name is Aoife Boyle and I'm Youth Mental Health Lead for Crisis Cafe. And I first joined the cafe in September 2020, and then a few months later I was asked to join the advisory board. And being on the advisory board has brought me so many new experiences and I've made so many new friends. Something I love about the cafe is if you're seeking mental health support with them, you're not inclined to stay for so many sessions and you're never forced to leave after so many sessions. Crisis Cafe is a safe and welcoming place for young people who find themselves in crisis or in need of mental health support. The aim of Crisis Cafe is to maintain an inclusive space that is non-prescriptive but is facilitative in a way, empowering young people to seek help in a non-stigmatising way. Our vision is for all children and young people to experience life with a healthy and resilient mindset. We have various cafes for young people to access support, which can be accessed at differing times according to individual need. The one-to-one drop-in cafe offers young people therapeutic assessment and intervention on all aspects of emotional, mental health and well-being, or they can benefit from sitting within a safe environment to have time out from the stressors that they're experiencing in life, or maybe if you just need a chat with someone. The Friendship Cafes offer peer-based support and group activities to promote positive mental wellness. This provides young people many opportunities to form vital connections and receive support. We also have an LGBTQ+ support group, peer support group, which meets weekly. This was developed and continues to be fully organised and led by young people. We also facilitate various workshops, ambassador programmes, peer support groups, and have advertised on our social media platforms. We have a community cafe which is open to the public, and it's a pay-it-forward cafe where all the profit goes to ensuring that Crisis Cafe can continue to provide for young people and with easy access and non-referral mental health support. Young people are trained up to work in the community cafe. Social Bites is another one of our cafes that we piloted and hope to develop further. It's an inclusive space working towards reducing inequalities for those experiencing poverty and deprivation. It's a cafe where all young people aged 11 to 18 can get a free drink and hot snack, access to technology such as laptops, tablets, printers, scanners and Wi-Fi, as well as access to mental health support. We also place a lot of importance on the creative arts, which you will hear more about from others speaking today. As you can see by that, there's something for everyone at Crisis Cafe. Thank you.
Hiya, my name is Fergal Hughes, and today I'll be speaking about my experience losing a close friend to suicide. On the 6th of November 2017, when I was 14 years old, I woke up to get ready for school. I felt anxious and completely overwhelmed, and after talking to my mother, we thought it would be right for me to take the day off, as it just felt too overwhelming for me to even think about walking through school doors. This wasn't unusual for me. I had a very rough time adjusting to school and to life in secondary school, to the point I had to call home after each class to ground myself and stop myself worrying too much. At around 3 p.m, my mum came to my bedroom to talk to me about an email that had been sent by the school to inform all parents about the tragic passing of my friend. I immediately broke down, inconsolable, in my mother's arms. I couldn't believe it. I received a phone call shortly after from my music teacher when they realised I wasn't in school that day. One of my best friends had taken his life that day. He was only 14 years old. At this moment in time, there was limited time with our school counsellor, and I found it impossible to get out of the car once we had arrived at the school in the days that followed. The emotions I felt were so strong, it felt as though I couldn't breathe. It was so overwhelming. I asked my mother to take me to the doctor to see if there's anything we could do. I had regular checkups with my doctor from that point on, but wasn't referred to any grief counselling or mental health support. The school put in place a room where I could go to remember him. I would have spent a lot of my time there in between classes and on break. I constantly thought about what I could have done to prevent this or how I could have helped. It was such a lonely and isolating time for me. On the year anniversary of his death, the school held an assembly in which they asked me to speak without any prior warning. I wasn't able to get any words out and ended up not speaking at all. My form teacher spoke on my behalf, and our new principal spoke about how no emotion is ever worth the pain that you could cause yourself. However, right after he spoke, my year head at the time gave us a rant about how our grades weren't good enough and how nobody was working hard enough to get our GCSE grades and that our entire lives depended on it. We all left that room feeling horrible. It was around that point in time when I went to PIPS, which in turn got me referred to CAMS. Up until that point, I had been coping with support from my family, but I had gotten to the stage where I was having dark thoughts myself and was afraid I would lose myself. Everything in the 2-year span, felt like a blur. Nothing felt right to me. Unfortunately, only a few months after I'd started with CAMS, we were just going into lockdown, and they were no longer doing face-to-face sessions. I'd gone from having a session with them face-to-face once per week for roughly 2 months to only getting one phone call a month. During lockdown, I threw myself into writing music. I recorded an album with my band that explores the stages of grief that I had been feeling after the loss of my friend. When we finally were back face-to-face, my counsellor told me that the only reason sessions like that were starting up again was because somebody she was seeing had taken their life. When she said it as if it wasn't a big deal, a throwaway comment in amongst our conversation. I'd made the decision that this was no longer for me. I couldn't deal with how they were treating my emotional well-being. A few months after leaving CAMS, I had found out about Crisis Cafe. A friend of mine had suggested I go down with him for one of the friendship cafes. That day changed my life. Since starting the cafe, I've found a supportive friend group where I can be myself in a safe environment and talk to people my age for peer support as well as one-to-one support if I ever needed it, which is still available to me at this time. I've been with Crisis for around 2 years now, and I'm now the creative director alongside Jessica, who you'll be hearing from soon. This year will mark the 6-year anniversary of my friend's passing. So much has happened since, both positive and negative, but at this moment in time, I'm the best I've ever been mentally. I now have a stable, supportive and loving friend group, multiple creative outlets for my music, an amazing girlfriend, wonderful supporting family, and I'm currently studying at university, focusing on my passion for music, as well as working with the Crisis Cafe to fund and organise music events and music lessons for those who attend. I feel it's important for me to give back to the same community environment that helped me in my time of need, so it may do the same for a new generation in a way that the current provisions just don't cater for the likes of CAMS. Even though it has been so long since his passing, my friend will live on in everything I do. An experience like that is not one that will ever leave me, and I'll always keep him in my heart and in my mind in everything I do. So what this process of seeking out help has shown me is that we need more peer-led and organised services with clinical one-to-one help, like Crisis Cafe, available to our youth across Northern Ireland. The impact that this model has had on me and so many others in my life is immeasurable. Not having the stigma that so commonly surrounds mental health and to be a burden on conversation, and seeking out help being a strength rather than a weakness. I hope that you can all take something away from my story. Thank you for listening.
Hi, I'm Olivia, one of the proud advisory board members of Crisis Cafe. Since 2020, I have watched our cafe grow in the most inspiring, positive way. When I first heard of Crisis Cafe, I was instantly intrigued and excited that something like this was happening so close to where I live. Helping others improve their mental health is something I've always felt determined about. Hearing about how non-clinical, casual, and inclusive Crisis Cafe was felt surreal. It was something I'd always wanted. A safe place for young people of any lifestyle or identity, somewhere teenagers never felt out of place or like the elephant in the room. I attend the cafe weekly for one-to-one support counselling they offer, and most other days just to see my friends or volunteer with the younger people. And on my bad days, no matter how hopeless I feel in life as a young person, knowing there's a place to turn to on those days where I feel I can't leave my room is vital. I find that I can usually muster the strength to get out of bed because I know Crisis Cafe will be opened. Having this open 5 days a week, youth-led place is crucial for all young people to access. I have history with trying to access the right support for my mental health, and Crisis Cafe is the most successful one in terms of my personal progress. I have never felt so listened to and understood. I believe having lots of crisis cafes is the ideal support solution for teenagers in our generation. The transition into teenage years is really tough as it is, without added mental illness or lack of options for support. I feel very lucky that in my time there is a crisis cafe, a safe place for anyone who needs it. Its friendly environment is one of the essential qualities a mental health support system should have. There's a gathered sense of understanding and unity within the cafe. It can help a young person to physically see for themselves that they are not alone with whatever they are struggling with or feeling, while also expanding their social circle and meeting all different types of people. Growing together as people and friends the last few years has been so inspiring and beautiful to watch. I know a lot of people would agree with me when I say the cafe has truly changed my life in the most positive way, and I will be eternally grateful for the cafe. I can genuinely and gratefully say Crisis Cafe gives us great hope for the next generation and the next in breaking stigma around having mental health issues and providing hope of a more understanding, open-minded, united and patient society. Crisis Cafe was the first to do something about the fact it's time to take young people's words seriously. Thank you for listening.
Hiya. So I'm going to kind of take a different kind of track of everything we've talked about. So obviously we've heard about kind of my peers' stories and how much the cafes help them. But I want to talk about how music very much impacts our mental health and how I've seen that in the cafe. So my name's Jessica McClatchy. Professionally, I go by Jessica James, and I am the creative director of the Crisis Cafe, and I'm responsible for hosting the music events as well as teaching guitar lessons. Music is in everything we do. It's in the rustle of the seats and the murmurs in the audience. It's in when we hear the birds chirping in the morning or the songs we hear on the radio. Each one of us has a personal connection to music, whether it's your favourite song or that band that really shaped you growing up. We're all connected by it. A 2020 study by Harvard Medical School found that music can have a clear and immediate impact on our mental health. For example, easing our transition to sleep with a soothing playlist, or aiding those emotions of self-expression. But most importantly, when we experience music together, we're connected by it, the sound and the people, and through that we find a sense of belonging. During high school, I had a very hard time fitting in and making friends, which made me experience feelings of isolation and depression and suicidal thoughts. But even with all those emotions, I had something no one could take away from me, and that was my music. Since I was 8, I've been playing guitar, and I've been singing ever since I could walk. So when I had a bad day at school, I knew I could come home, and there was this world that was mine, and I could pour all my emotions into this world, and it wouldn't judge me. I could stream the lyrics of an angsty pop-punk song, or write my own lyrics and play them over the only 4 chords I knew. But it didn't matter, because it was my outlet, and it understood me. When I was at high school, I was graded to a very underfunded music department. There were loads of guitars, tons of them, but only one worked, because it was the only one with 6 working strings. When I had to record my composition for GCSE, I was given a beginner's microphone, which I had to duct tape to a broken mic stand, and I recorded that composition on the first ever version of GarageBand, which for context came out in 2004. That was the year I was born. When I attended, there was no school band, there was no shows to showcase students' talents, and there wasn't even a school play. And then in 2021, the UK government announced that they were cutting 50% of funding for all higher education art courses in England, which would subsequently affect any Northern Irish student, but also affect and trickle down into our own Northern Irish Assembly and affect where they decide to put their funding, whenever they do decide to be a government. But the lack of understanding by the government and how important it is to push creative minds and talents in this country is absurd. So I'd like to tell you 5 key facts about how the music industry affects the UK economy. The UK music industry contributed to 5.2 billion to the UK economy in 2018. The live music sector made a contribution of 1.1 billion. Employment in the industry hit an all-time high of 190,000 people. The total export revenue for the music industry was 2.7 billion, and music tourism alone contributed to 4.5 billion. Although these statistics are pre-COVID, I think the pandemic showed us how much community matters. During that time, many of us looked for a creative outlet such as music. People started learning new instruments, posting videos online, learning how to record their own songs, or hosting live stream concerts, which was actually the first concert the Crisis Cafe ever held, and it reached such a wide audience. As I've stated, during the pandemic, many of us used the arts for our mental health, and the UK government's response to that, obviously, was to launch now Prime Minister Rishi Sunak's ad campaign telling creatives during COVID to rethink, reskill and reboot. This is disgusting. As we can see, this stems from the UK government not acknowledging the amount of jobs and income the music industry generates for the UK economy. Thus, when budget cuts need to be made, they feel no guilt about slashing the funding for arts in schools, which at its core affects the student. It affects their mental health. Because there's a child that looks forward to music class every week but doesn't have the resources necessary to advance their learning. There is a child that enjoys music as an outlet to express their emotions but who now feels discouraged because with budget cuts they can no longer run an A-level course or any extracurricular music activities. I was that child, that was my experience, but like I said, music saved me and it has saved so many other people, and that's what I've seen with my work in the Crisis Cafe. I started going to the cafe in 2021 and it helped me come out of my shell and make new friends who've become like family to me. Most importantly, it rekindled a friendship with Fergal Hughes, who has already spoken to you today. He's also a creative director for the cafe. I've known Fergal for 4 years. We met when we were both young musicians gigging around Newry. We found there was no safe or encouraging place that really boosted young people's musical voices. Mostly the only places that would let us play were crummy old bars full of old drunk men who only wanted to hear Wonderwall or Tennessee Whiskey. By rekindling this friendship, we once again connected through our shared love of music, which very thankfully sparked a romantic relationship between us, and that helped us both work through our hardships and our mental health together. So we decided we wanted to give back to the community and give young people what we wish we had when we were growing up. As organising these events through the Crisis Cafe, we have given young people the opportunity to express themselves in a safe space with no judgment, connect with others by enjoying the music, and also inviting them to take that first step into the cafe and get the mental health support that they need and access to those facilities. These music nights are a break from reality from young people, from the stress of school and their home life. They can come down to the music nights when they have this outlet where they feel like they belong, where people dress the same, they've got the same interests and same shared experiences. I wish I had this opportunity growing up, but I'm so happy that I can give that back and give young people this self-confidence that they may not now get in music classes in school. So what I hope you take away from my speech is how important connection is. We're all connected. We're all in this room today. We're all connected. We're all here because we care about young people and we want to see a change. So we're connected to the art and we're connected to the world and each other. From listening to my story and my peers, I really hope that you can see how much community and love Crisis Cafe has brought to Newry. It really is the shining light of our town. Crisis Cafe has always been a big supporter of the LGBT community and the inclusions of others in creating a welcoming environment, because I know that it's always going to be a home to me, a friendly place where I can call in and just have a chat about my day or how I'm feeling, and a cup of coffee as well, whenever I need it really. But I know what me and Fergal have done and started will always live on through the cafe, and I'm so thankful for that. So I urge you to recognise how important the arts are. And I urge you to recognise how they do save lives, they do improve people's mental health. So I urge you to support that change. Thank you very much.
Hi, I'm Dara Doyle. I'm on the board of directors and the advisory board for the Crisis Cafe. The Crisis Cafe is a youth-led initiative for mental health in young people, but it's impossible to explain how much more it truly is and what it means to all of us in our community. I'm always grateful to speak here with my friends and try as best as we can to explain to you all the cafe and all the positive impact it has had, big or small, in the lives of so many young people. When I first walked through the doors of the Crisis Cafe, I was a very different person. I was anxious and unsure of myself. I didn't know where I fit in, and I took a lot of my difficulties out on myself. Walking through those doors, as I've described many times before, was very scary for me. I'd always struggled with my mental health, and I was very used to going somewhere and being met with a cold clinical environment that I, as a young person, was not tailored for. What I found, though, when I went to the Crisis Cafe instead was a warm welcome like I had never experienced before. Professionals that understood and used their full capabilities to help each individual that attended, and a community of young people that understood each other and looked out for one another. What I found was some of the most important and long-lasting friendships I've made in my entire life. The Crisis Cafe, as an idea for providing clinical support to young people in a non-clinical environment, was something I had never seen or heard of before. But one I found to be much more suited to the comfort and well-being of its members. I'm one of many young people that has been very lucky to access the Crisis Cafe, and this did more for me than just my mental health. The youth involvement of the cafe, empowering young people and teaching us a sense of responsibility, has been something that I've been lucky enough to benefit from. The Crisis Cafe, of course, have many ambassadors and a brilliant young advisory board that I'm proud to have been a part of and spent a year co-chairing. The dedication I've seen from the young people to put back into the cafe and use it as a creative space will never fail to amaze me. The empowerment the cafe gave to young people like me who had experienced poor mental health to go on and become ambassadors for mental health positivity was overwhelming. Before long, I could feel myself becoming more confident, and it was a rewarding feeling to be able to support other people at the cafe in the same way I was supported when I first came in. Being involved in the cafe led to so many opportunities, taking a leadership role I never would have seen myself capable of before, helping me to realise my passion for mental health work and eventually decide to study psychology in university now. The Crisis Cafe caters to young people's needs so much, in large part due to its youth-led aspect, in the beginning being largely advertised on social media. This is how I originally heard of the cafe, and it was a great format for young people to share and learn that there's a space out there filled with positivity and trying to break the stigma around mental health. The cafe has many different aspects, some peer-led and some delivered by professionals at the cafe, but each providing very necessary and different support. Our drop-in cafe provides an opportunity for young people to chat to Louise or Grania, receive a strong level of professional support. We have an LGBTQ+ support group run by young people for young people that creates a safe space for us and knowing we're not alone, formed by my friend Kira and I when we realised there were so many young people that went to the cafe and were struggling in school, at home and in their wider communities. We wanted to provide a safe space to talk, share information and experience in a positive and open space. Social Bites, a programme run that provides young people with free food and access to technology as well as a relaxed environment where we can study or socialise, a programme which I think particularly can help people with varied socioeconomic backgrounds. And finally, the Friendship Cafe, that helps people to form connections, and personally I find it's a very safe space for people with social anxiety to get more comfortable around others. Anyone can come to any of these programs whenever they like, and nobody has to go at any time. And I think that level of varied support and voluntary involvement has been critical to helping young people who come to the cafe grow confidence, security, and a sense of belonging. But most importantly, to provide support to young people how they need it. Putting young people at the forefront of this project, the youth-led aspect, and the influence young people like us have had in the way that we can receive support is something I'm proud to be seeing, and I'm delighted to say is succeeding every day with people like me, some of my newfound closest friends, and new people that walk in every day and discover a wealth of opportunities and support that I could never have dreamed of when I took those nervous first steps through the doors of the Crisis Cafe. Thank you.
Good morning. I would firstly just like to thank Siobhan and Kifa and everyone for organising this, for inviting Crisis Cafe here, and to Louise and Grania for inviting us to speak. My name's Inez. I was previously on the Youth Advisory Board for Crisis Cafe, and I'm now Chair of the Board of Directors for Crisis Cafe. It's a privilege to have been asked to speak about my experience with Crisis Cafe, because if you had asked me to speak a few years ago in front of a crowd like this, I wouldn't have been able to. And I'm about to tell you how that all changed. So let's start at the start. What is mental health like in young people my age in Northern Ireland? A recent study from Queen's University Belfast found that 1 in 8, 12.6%, met the criteria for any mood or anxiety disorder. 1 in 8. That's a pretty big number when you think about it. It's a bit scary, really. But what's scariest is that it's not just a number. It's real young people. It's young people like me and Dara and Jessica and Fergal and Aoife and Liv with our whole lives ahead of us. Struggling. At Crisis Cafe, we see these young people, we help them and we understand them. I wish I could share with you today all of the stories that I've heard in Crisis Cafe, but unfortunately, due to time limits, I can't. So I'm going to share one with you, the one I know the best, and that's my own. This is the story of how Crisis Cafe helped to change my life. My name is Inez. I'm 20 and I'm studying at university now, but for as long as I can remember, I've been anxious. Although I didn't know anxiety was a thing until a few years ago, it's been something I've struggled with for years. Insecure, worrying, overthinking, stressing. I was trapped in a cycle of anxiety triggered by academic stress that our school subjects us to at such a young age. Eventually, I knew it wasn't normal and I reached out for help. I was put on a conveyor belt of counselling. I sat in sterile doctors' offices, separated by a desk, or, during COVID, I sat alone, behind a phone. I was given worksheets to complete, and my counsellor was given boxes to tick. I tried to open up. I tried to make it work, as I knew how privileged I was to have gotten these sessions. But how much can you say in an environment like that? I was afraid of the consequences of opening up. How could I trust a stranger with my feelings and my fears in 6 short sessions? One day, I was asked when my 18th birthday was. I smiled because I thought that was a really thoughtful thing to ask, as it was just around the corner. I was then informed that my next session would be my last. I was cut off. It's very hard to describe the hurt that I felt at that moment, because I knew that I still needed the support more than ever. I felt betrayed by a system that was supposed to support me. Because 17, 18, 19, these are the ages that things are constantly changing. Everything that you know that feels comfortable and safe slips away as you transition to further education, university or work. Life goes all over the place, and a pandemic only adds fuel to the fire. I was an adult on paper, but in no other way. I was a young person in need. And what did I need? I didn't need a sterile doctor's office. I didn't need to languish on a long waiting list for help. And I didn't need medication that I didn't understand, because I was told that it was only an option because the waiting list was indefinite. It would be months before I sat in front of a counsellor, if at all. All I needed was someone to talk to. I remember saying this down the road to my GP when I was at my lowest. And in all my need, all they could offer me was sorry. The waiting list was almost indefinite. I needed someone to talk to. I needed someone I could trust. I needed a community of people who understood me. I needed Crisis Cafe, and I thank goodness every day that it was there for me, because this is where the story gets good. This is where Crisis Cafe comes in, and this is where the hope comes in. Around the same time that I was cut off from CAMS, I received a message from a stranger who would go on to become a great friend, asking if I wanted to get involved with a youth-led mental health project called Crisis Cafe. I was up to my eyes in university applications, but I was intrigued, because you have to understand, when I was growing up, which wasn't that long ago, but if you speak to some of the teenagers at Crisis Cafe, they will try and convince you it was. We didn't talk about mental health. At best, we talked about stress and well-being and resilience, but no one actually used the words mental health. In fact, I was told when I was in school that if we talk about mental illness and poor mental health, people might actually think they have it. But as you've heard from the statistics, they do. 1 in 8 young people do. In a school of 800, that's 100 students. 100. The statistics do not lie. So to hear someone actually use the words mental health seemed like a little revolution in itself. Crisis Cafe acknowledges the issue at hand, and more than that, they're actually doing something about it. One of, in my opinion, the most important things about Crisis Cafe is that it is youth-led. Because when I heard this, I was surprised. Even when mental health had been mentioned, we were talked to, not talked with. But Crisis Cafe listens, and they actively show that they listen and they care. That alone makes a world of a difference to a young person like me. Because they listen to all of our ideas, no matter how outlandish they may seem, and there have been a few of those. During lockdown, it was Crisis Cafe's ability to listen that enabled us to empower young people to create a self-care calendar to talk about issues like body image, anxiety, loneliness, isolation, academic stress. We would host live videos with young people and do daily posts about what we can do to help improve self-care for young people. We also hosted Study With Me live videos when there was no school in person, so that young people could connect with other young people their age. We've hosted music concerts and fashion shows and everything in between. We provide a safe space for LGBTQ+ young people in our local area through a weekly support group. I could go on, but you think you get my drift. Crisis Cafe listens to what we need. They care and they listen. Because so often, young people like me and the others here today don't get heard. Our stories and our opinions don't get factored into how things are run. But at Crisis Cafe, we matter. Louise and Grania have put into action a model that has considered the gaps and the drawbacks in the current provision of mental health support in Northern Ireland. And they have listened to young people who know firsthand how to make it better. At Crisis Cafe, you don't have to wait on a waiting list. You walk in. You don't have to worry about how many sessions you get. You take what you need. And you aren't sitting behind a clinical desk. You're sitting in a warm, bright, colourful room, comfy chairs, with a fresh coffee in hand, as private as you want it to be. You feel comfortable and able to open up. Once your session is done, you don't go back to feeling how you feel alone. You head over to another table in the cafe full of friends who know what you're going through, who care about you, and who are there to support you the whole way. You feel safe, you feel at home, and you feel hope. It's very difficult to put into words how it feels for me, even now, to walk into Crisis Cafe, because it's not just a building or a group of people. It's a community. It's smelling freshly brewed coffee and knowing that it's going to be okay. Because when Crisis Cafe is with you, it is. I hope I've been able to give you a glimpse of what Crisis Cafe is like and what it has done for young people like me. When I walked through those doors nearly 2 years ago, I was insecure, struggling, and ashamed of the battle that I had with my mental health. Today, I stand before you, confident and capable, and ready to take on my own future. I wouldn't be where I am today without Crisis Cafe. Thank you to Louise and Grania and all the young people who have helped me and so many others at Crisis Cafe. It has truly been life-changing. Crisis Cafe supports young people, but it also needs support. Please, help Crisis Cafe continue to change and save lives. Thank you very much.
I'm just going to give you the mic so you can pass it along for whoever. Thank you so much. I don't know about everybody else. That was amazing. Inez, the only thing I will say is that comment about the younger people making you feel a bit old. Think how all the men in the audience that like to listen to Wonderwall are feeling. Who described them as old men? That's an outrage. Absolutely brilliant. We've time really only for 2 questions because we have to get to the breakout sessions, but I just wanted to read a bit of the feedback we've already got through. Crisis Cafe sounds like a brilliant idea and should be replicated everywhere. That is something that about 20 people have said. Fergal, thank you for sharing your very touching story. You've challenged us to refocus on the things we can do and not be overwhelmed by the sheer size and complexity of youth suicide in our communities. That's from Phil. Louise also says, very brave, all of you. The cafe concept sounds really exciting and much needed across rural areas and urban areas. And it's a shame there wasn't more funding for these cafes around, as these would do so much good for young people with mental health issues. Absolutely fantastic. Let's give them another round of applause. So just one roving mic, so if the questions could come from that side, that would be good. Oh, here, we have one at the front here. You're all right. We'll do pass the mic again. And then whoever wants to answer it there, there's a roving mic here as well.
So I'm Jill Gordon from the Well in Kilkeel, and some of you guys on the stage are working with me at the minute to co-design a project for schools in terms of suicide prevention and awareness. But what struck me really from this morning so far is that we had at the very beginning that 50% of people, young people that attend CAMS, don't find it helpful. And ourselves in the Well, who we work with, adults and young people, 89% of people coming through our doors have been to statutory services and found them unhelpful and end up with us in distress and despair. Now, as we work together, what I would love to hear from you guys now is enough's enough. We see young people suffering around us. We see young people in Northern Ireland dying from suicide. What do you guys, as young people, think need to happen in Northern Ireland to make a change right now?
Brilliant question. Thank you. Who wants to take the lead on that?
Yeah. Thank you so much for your question. I think you're so right. It's not that young people aren't reaching out. It's that when they do, they're not getting the services that they need and services that can actually help them. I think what we need to do is to listen to young people. And I think, first of all, we need to have funded services. Crisis Cafe is a voluntary service. It's run by the community. It's run by wonderful people like Louise and Grania. But we need to fund it. When the government isn't doing it, we have to step in. I think we need a government as well to start funding this. And I think that the policy we make surrounding youth mental health and youth suicide prevention, it needs to be youth-led. The people on this stage here today, we've been through it. We know what services work and what don't work, and we're ready and willing to tell people. We just need to be listened to. Does anyone else want to?
Yeah, anybody else want to pick up on that? No? You happy?
I think what Inez says is absolutely right. The funding and the support for young people going through CAMS, or even the support in the third sector for people that would be coming to places like the Crisis Cafe or the Well, or different places that would be more suited to their sort of recovery style. The support needs to be there, and I'd say as well, it needs to be there for all young people, not just the ones that meet certain criteria or the ones who are maybe put onto a high risk, because I know a lot of people go to CAMS and they don't get support that suits them. But I know that there's a high number of CAMS applications that don't get seen because they don't meet certain criteria. A lot of young people I know with special educational needs or who are suffering from grief are told that their sort of suffering is situational. And I think that the big thing that I think is needed is support for everybody that needs it, and not just the people that meet a certain criteria, meet a certain tick box, or meet a certain threshold of you are suffering enough.
It's a really good point, and I think one of the other things, I'm sure everybody agrees with this, is, yeah, we'll come to your question, it's the second one now in a second, but that idea of social cohesion that we've had right across the day, and the fact that you're all able to come together and get support from each other, whether you're in serious crisis or something, you're on recovery or whatever stage you're at. Thank you. So we'll take this final question just in the middle of the row. Pass the mic again. Thank you so much. Thanks.
Thank you. Renee from PIP's Suicide Prevention Charity. I note the call for government funding to help support services. So we are a charity that provided over 15,000 sessions last year with no government funding. We have never received government funding for our services, and the reason for that is because government funding is too restrictive. The fact that we can operate our services voluntarily with fundraising, with families who support us, gives us the freedom to provide more than 6 sessions, to have the crisis walk-in service that we have. I think whilst we call for more government funding, I actually think the government needs to be held to account for how they disseminate that funding, and the very, very tight criteria. It's time for change. The old models and the old ways of working does not work. We are in a situation where people need access to good health services, but the health services need to catch up and think of something different. I would encourage anyone in this room who has influences with MLAs to please consider loosening those chains around funding to make it easier for community organisations to provide the service that we know works, which is free, accessible, crisis, non-restrictive services. That's where government needs to be at.
Okay, it's less of a question, but really useful, and lots of people nodding their heads. Can I borrow the mic for a sec? I just want to give that down to Siobhan, because I think there's some really good points raised there that you might want to answer.
Hello. What I'm going to say is, Tara, we should agree a signal so that anybody that says anything that's in the mental health strategy, so I wouldn't have to keep saying this every single time.
Yes.
But that is the vision, honestly. And when you look at the model for a regional mental health service, there's provision in that model which is now available. So you know the story with the strategy.
Yeah.
We're moving, we're implementing parts, but we do need the funding then, and we need an executive or some other way to deliver that. Thanks.
It's interesting because I think if we go back to the point that you made earlier on about 20 years ago and the services that came out of that, if you look at things like PIP was exactly the same, and lots of the other organisations here, and Crisis Cafe is a fantastic example of that as well. So thank you all very much. That was really fantastic. Well done. Brilliant. So we're going to do the breakout sessions. I think everybody probably knows which one they've chosen, but just to reiterate, suicide in the media on the 6th floor, LGBT plus youth suicide prevention and practice here, and postvention with Barry McGill on the 4th floor. See you soon. I know, Fergal, that was amazing. That was fantastic. Absolutely brilliant.
Thank you. I'm going to go up to the 6th floor with you because I want to see Lorna.
Yes.
How she delivers this with for young people. Do you know what I mean? Even though I want to stay here with Hazel as well.
Hello again. Gosh, what a day. It's buzzing, isn't it? It's buzzing and fizzing. It's just been fantastic. I hope you enjoyed your breakout sessions. I was up at the Samaritans one upstairs. It really was fantastic and really useful reminder for anybody working in that kind of sector just to be so mindful of how we put that message out there and how we treat stories. So it was very, very useful. I hope yours was too. I'm delighted to introduce Professor Ella Arnsman, and thankfully she didn't come from Cork this morning because that would have been a very long drive. She arrived up last night, but we were just talking there, and I know Siobhan touched on this morning as well, that probably the most important thing in this field is to keep an open mind and not to be, if we think of the Crisis Cafe and everything that young people told us this morning, it's just about kind of always learning, always looking and seeing, are there better ways, are there other ways to do things? And that's, hopefully the thing that will lead to prevention and continued prevention in the future. So we're delighted to have a professor from the University of Cork with us this morning, and really that's what this presentation is about. It's looking at risk factors and how we can prevent youth suicide. Welcome.
Thank you. Thank you very much for that kind introduction, and it's absolutely wonderful to see so many people here, and again to be back in in-person events, which definitely makes a difference. When there was just a mention about that I will at least give an overview of important updates on risk factors, I'm also going to share with you protective factors and hopefully some solutions for the important challenges that we are facing in relation to youth self-harm and youth suicide. During this, first of all, I also would like to highlight, I don't know if it was coincidental or not, but this week there's also International Self-Injury Awareness Day. I know this conference was supposed to happen historically already before, but I would like to highlight the importance of global awareness, but not only awareness, trying to move the government, the policymakers also to action. And then not just any action, but certainly evidence-based and informed actions. And that is also what I would like to hope to convey to you today. Also, many congratulations to Siobhan on organising this excellent programme. When I was looking at the programme, I thought I can't really detect a specific gap or a hiatus when we really talk about all the important components to be prepared for further increases in self-harm and suicide, but also all the components in this programme also highlight what is needed for an evidence-based suicide prevention programme, and particularly with a focus on young people. So what I hope to do in this coming hour is I will start with an update on trends, risk and protective factors in relation to self-harm and suicide in young people. When we go along, I also have some questions to you, and there's at least one question that's attached to an award. So say keep listening carefully, and I hope there will be ample space for questions at the end. And I also hope to share with you some very insightful and engaging testimonials of real young people, not actors. But about a few years ago, I worked together with the director on a very insightful documentary, My Other Life. Some of you may have seen it, but there's a few important scenes and statements from young people that I think are definitely very encouraging and also highlight the use and the implementation of evidence-informed interventions for young people at risk of self-harm. I hope during this presentation also to highlight some aspects in relation to suicide contagion and clustering, because if we talk about young people and increasing trends of suicide and self-harm, the topic of contagion and clustering is very important, but it's still usually a gap area when we look at the programs that are available in mental health policy or suicide prevention policy. Just a quick update. Also, I start with an iceberg, and I start with an iceberg that gives scope for concern, for worry, and has to push us to action. But later on, I hope to end with a more hopeful iceberg, whereby I also can highlight the relevant evidence-based actions, whereby we really can pinpoint those important challenges along the iceberg. When we talk about the Republic of Ireland, there's still that worrying phenomenon of when we look at 15 to 19-year-olds, we're ranking fourth in Europe in terms of the highest rates of suicide, both in girls and boys. But then in terms of the iceberg, so on top of the iceberg we have an approximate 550 cases of suicide per year. It's an approximation. And the real number is likely to be higher because we have evidence and indications for an underestimate. Then, in the middle of the iceberg, we see the annual outcomes of the National Self-Harm Registry. Northern Ireland and ourselves, we work together in terms of also the Northern Ireland Self-Harm Registry, but a worrying 12,000, I would say at least 12,000 cases of self-harm coming through the door of emergency departments. And then this astronomous figure of 60,000 cases of self-reported self-harm, whereby we obtain this information from school-based surveys or other population-based surveys. So some of you here may think, what is the top important intervention or prevention program? My answer is already, there's not a single one. It's a multitude of multifaceted actions, and in some of my European collaborative work, particularly with the European Alliance Against Depression, we learned that ideally we should not have ad hoc once-off interventions, but all together in a very well-coordinated framework or package, whereby we then finally could see the intensity of simultaneous interventions and positive effects. So I'll disentangle that a little bit later, but that's just to highlight that a bit more clearly. Yeah, so when we talk then of the Republic of Ireland, but it's a bit mimicked with the prevalence rates and incident rates of self-harm in Northern Ireland as well. Obviously, we saw a huge increase of self-harm, particularly amongst males of all ages, during the historic recession. But during a 10-year trend analysis in 2018, the rates were still 29% higher compared to 2017. So we haven't seen real peaks, but also we haven't seen a convincing reduction. I consider this real trends because we see similar patterns when we compare boys with girls. And the other very worrying phenomenon, which wasn't so clear when I started working in this area in the 80s and the 90s, but certainly over the last 10 years, we've seen a worrying increase in the use of highly lethal methods of self-harm. And again, there's not one answer to why that is, but certainly the fast-speeding social media, but also the exposure to very specific, explicit, harmful methods could certainly be one of the triggering factors. I wouldn't say immediately causal, but certainly triggering. Keep going up and down. I'm not sure if Nav Kapoor this morning mentioned children, but for a long time we focused on adolescents and young adults. But only in recent times, there was in the UK, based on the UK self-harm monitoring study, a really worrying publication on a relatively, or at least higher than expected rates of self-harm amongst children under the age of 12. And for quite a long time, we were even assuming that self-harm wouldn't be very prevalent. So this is a publication of last year. Really very worrying findings. And when we look at adolescents and young adults, we see usually slightly higher rates of non-fatal self-harm in girls. But here we suddenly see the boys being overrepresented. What's also very worrying, and again, this is not for the media, not to bring out to the media, a relatively high level of analgesic, so particularly paracetamol. And for children at that age, where do they access that? Obviously in the household. So there is that also underlines the importance of liaising with parents, but also with teachers. This also very much highlights that in developing intervention and prevention programs, we have to think more upstream. We have to be less reactive. So, and I come back on some examples there later on. Again, for children, we wouldn't have expected that nearly 30% would engage in highly lethal methods of self-harm, so that's worrying as well. And then amongst this very young group, we see about 1/3 already engaging in repeated acts of self-harm. In terms of repeated self-harm, Professor Nav Kapoor may have also mentioned maybe some facts, but I just want to highlight that is also very prevalent amongst young people, and obviously many people know that may be related to some extent by self-cutting, but we see it also in combination with other methods such as intentional drug overdoses. One of the new insights, and again this is really important also for people in educational settings or primary care, in recent times we have picked up with our National Self-Harm Registry on a much shorter windows of time between a young person engaging in a non-fatal act of self-harm or maybe superficial self-cutting. So the time window to a slightly more lethal act of self-cutting or self-harm is shorter and is becoming shorter. So that is definitely something that has to be taken very seriously with assessment, because I still think of some of the guidance counselors that I trained in the South, and they said, "Oh yeah, we saw people with some cuts, but they didn't need treatment. It's maybe just a trend or a fashion." And I said, "No, this is really something to take seriously until you know what is the explanation, until you find out and assess what are the underlying factors." Then, of course, we have to touch obviously on COVID, but particularly here and now, a good few years after COVID. But many of you must have seen the very worrying statements in the media. This started already in the first months of COVID-19. These are just a few examples. But if we were to believe the media, then already very early on, in the early months of COVID in 2020, we were probably seeing or expecting an epidemic, or even some statements refer to another pandemic of self-harm, and particularly amongst young people. Is the media right? Was the media right? What do you think? Yeah, there are people nodding. Okay. But do you think they were right all the way from the very start? No. Okay, yeah. That's in some extent, I think, the answer, even though we still don't know exactly the very long-term impacts of COVID-19. It's not only COVID, it's obviously lockdowns, other restriction measures, and obviously a lot of experiences that people were losing out. But what is certainly not the case, and we saw that about a year into COVID, very importantly, there was consistent evidence in the UK and in Ireland and in other countries of a significant increase in mental health problems, particularly amongst young people, so depression, anxiety, but also alcohol misuse and misuse of other substances. But certainly in that first year, it didn't immediately translate into a sudden increase of self-harm or suicide. The jury is still out in terms of low and middle income countries, but certainly I have to think quickly, but I think at least 33 middle and high income countries, there was no evidence of a sudden increase of self-harm and suicide in 2020. However, a little bit further on, here we see some evidence, interestingly, both of an increase in the use of psychiatric services, particularly a little bit further on in COVID, but also indications for a possible increase in self-harm, so associated with the second wave of COVID. So I think that's very important for us to take into account now in terms of increased capacity, increased interventions, but also increased preparedness. Starting with some important risk factors, this is an overview based on specific risk factors, all very significantly associated to episodes of self-harm in girls and boys. It's based on research conducted in Ireland, in the UK, and in 4 other countries. And what is quite striking is that there are more similarities in these risk factors when we compare boys and girls than differences. So I think this is definitely a very important constellation. So when people say self-harm occurred out of the blue, we don't know why, usually it's also an absence of information, not knowing that some of these risk factors were present. So it's absolutely, I think, important to take this into account in assessments, but also in awareness and skills training. Here comes the award question. So have a look. This is again an overview of the variety of different motives reported by young people, particularly adolescents, as motives associated with an act of self-harm. So it ranges from revenge to wish to die, but also relief from a state of mind. Now, when we looked at these specific motives in greater depth, we had expected that there was maybe at least a subgroup amongst these adolescents whereby they would only report wish to die. So where we would think this is a group that's associated with high lethality or high suicide intent. But amongst the several thousands, this is about thousands of young people, there was nobody who reported wish to die as the only motive. So wish to die was often combined with wanting to get attention, wanting to frighten somebody, but also self-punishment, for example. So if you think of the underlying process when somebody considers self-harm or possibly suicide, on the one hand, the person wants to die, but on the other hand, they want to achieve something else. What is that? What type of process are we talking about? So the person is certainly not determined. And also, this evidence does not support the so-called, and it's not the right terminology, but we hear this sometimes in emergency departments, an unsuccessful suicide, or which is not the right term. But that's not the case. The evidence isn't even there. So what is this psychological process? On the one hand, people want to die. On the other hand, they want to achieve a change, something important or something to improve. Who has the answer here?
Connection?
Sorry?
Connection?
It's not the right answer, but it links in with, let's say, a drive or still a motivation to remain connected. So it is different from wanting to die. Yes, but not definitively, because there are other motives as well. So who said that? The award goes to you. But it's not fair because it's a panel member. Ambivalence, yeah. So obviously, but yeah. So, and interestingly, because this was the first time we discovered this is a good few years back, but it really helped us a lot in terms of convincing, even without making all the efforts to try to convince hospital staff, GPs, but to say, there is much more going on when a person is considering taking paracetamol or engaging in self-cutting, because in reality there is still ambivalence, and there is ambivalence until the very end, or what I would like to say, until even when somebody is in a very acute crisis. I see some people nodding, so they may recognize Kevin Hines. Kevin Hines is very much an advocate of suicide prevention in the US. And I can't remember exactly the year, but here it says 16 years ago. So I would consider Kevin really the living example of evidence of ambivalence, because Kevin arrived at a stage in his life where he was very suicidal, and he considered jumping from the Golden Gate Bridge, which eventually he did, but he survived. And that was a miracle, because overall it's just about 3% of people who jump from the Golden Gate Bridge and who survive. And in hindsight, after recovery, he very, very clearly stated that at the time of this very acute suicide attempt, he realized that he didn't want to die. What he wanted was a different life. So it is really important, I think, to take into account not only the motives of all the young people, but certainly this very important underlying process. It gives you, step by step, in small steps, the opportunity to divert from the suicidal intent or the death wish, and to start step by step looking at anything that the person would like to make a difference or change in their lives. So moving on to some hopefulness in the iceberg, or related to the iceberg. I think one of the key messages to take away today, that there is not one single golden standard intervention that will make a difference, that will change the current situation of self-harm and suicide in young people. But it's the challenge to get it right in terms of all the different levels, and I was very pleased to hear that Barry McGill was doing a session on postvention. So at the very high level of suicide and the aftermaths, important proactive approaches need to be in place, but also following acts of self-harm where people has presented to a hospital. And then, and this is probably a specific big challenge, when I say hidden cases of self-harm, so people who reported cases of self-harm but who had not been in contact with a GP, with a mental health professional or anybody else. So that's obviously very, very challenging, how to reach these people and how to propose proactive approaches. The good news is that globally, for all the three levels, there is now a multitude of what I call evidence-based interventions. Today I can't go through all these interventions, so I'll just go through a couple of examples. So if we look at the middle level of the iceberg, then certainly for young people there are a number of important indicated interventions. There's growing evidence for evidence-based cognitive behavioral therapy interventions, either individual or group-based, at least with good outcomes on reducing suicidal ideation and reducing the risk of repeated self-harm. A little bit less, but emerging. There's some emerging evidence for dialectical behavior therapy for adolescents called DBT-A, but there's still some studies internationally where there's less consistency, and this is particularly indicated for young people, children and adolescents with highly repetitive patterns of repeated self-harm. Home-based family therapy, there's only a handful of evaluated intervention studies there, but with some promising outcomes, and CBT is again one of the components there. And brief compliance enhancement, this refers to when a young person is being referred by a GP to a next step of care, aftercare, that at least during that period of time, a couple of weeks or maybe even over 2 months, that they are linked to a gatekeeper or at least somebody who can motivate and engage them to seek that help and to arrive at the next setting of care. So there's an impressive increasing number of studies that have clearly indicated that CBT has demonstrated significant reductions in self-harm, repeated self-harm, improvements in depressed mood, but also trait anxiety, so the more longer-term stable anxiety. And also CBT seems to be beneficial, either in person or online, in terms of preventing a next relapse, a relapse of depression or anxiety or a next suicidal crisis. Usually you're looking here at protocols, around 15 sessions, not less. But the very encouraging outcomes is that there have been consistent positive effects also for people, young people with repeated patterns of self-harm. This is an example of an intervention at the bottom of the iceberg, so where we have major challenges going forward. But this is based on a large-scale European project, Ireland, UK, and several other countries. So the project is referred to as Saving and Empowering Young Lives in Europe, and an intensive awareness approach, the Youth Aware for Mental Health, was implemented in schools and showed significant improvements in terms of suicidal ideation, also depressive symptoms, and improved self-esteem. And also prevention of repeated suicidal behavior. For us, it's still a bit of a mystery as to why has this not been implemented more widely. It's being promoted and endorsed in the US and in some other countries, but I think this is definitely something, and I'm looking at Siobhan, finding Siobhan, but this is definitely something to put high up on the radar because of the consistent evidence. Similar positive patterns and outcomes were found across the 6 different countries, so that was not a coincidence. So I highlighted the patterns and the quantitative outcomes, but in this very large-scale project, there was also support from the young people themselves. So they highlighted a wide range of benefits in terms of using and receiving this program. Then, as a last, one of the last examples, but still there are many examples out, I would like to focus a few minutes on the European Alliance Against Depression. I think some of you may have heard about this because formally we're in existence nearly 2 years, but we have worked with some new EU funding recently to give EAD a new code and literally to refresh and optimize our resources, our information. But this, I think, is a really good and comprehensive example of working more upstream. So before a first act of self-harm has occurred. So the primary focus is not really on self-harm or suicide, even though the resources are included, but the primary focus is on early identification, in fact, of people with mild to moderate depression. And that's being incorporated in evidence-based training programs with primary care, with a wide range of community-based professionals, including the Gardaí, including people working in the school setting, public health nurses, etc., but also a comprehensive awareness campaign, and then also a specific focus on increasing proactive approaches to people who have engaged in an act of self-harm and to provide them with the required support. I didn't want to bring too many statistics today, but the precursor of the new optimized EAD four-level approach is really the only program that ever has shown a reduction of 33% of self-harm and suicide in a time space of 3 years. So that was the original intervention that was conducted in Germany many years ago. Increasingly, the European Union got sight of it, became interested, and started supporting some of our applications. And in some of the countries, this has become at least a regional or a national approach. In coincidence or not, but on Thursday evening in Cork, we have a specific evening whereby we have a launch of the newly optimized EAD approach. When we look at what is in this for young people, I particularly wanted to highlight the I Fight Depression online self-management tool. It's a self-management program online, and it's very much based on CBT. But the trick is we don't mention CBT. So in a very engaging way, there is a wide range of modules. So we have in total 6 modules which we advise people to take or to use and avail of on a weekly basis. And there's a very specific trajectory or a version of I Fight Depression focusing on adolescents and young adults. In Ireland, it has been implemented on and off, but now with the new resources, we give it a new push. And coming out of COVID, I think this is definitely a no-brainer. And many of our European partners got a huge uptake and interest, especially during COVID. What is quite unique about this online tool compared to some other online programs is that there's minimal guidance with it. But that guidance is very important and it's crucial because usually when people avail of CBT interventions, there may be a slight deterioration of their mental health symptoms in the first few weeks. And that may be the time where they say, oh, this is not for me, this is not going to help me, we leave it. So that encouragement and engagement and support, but it only requires on average 5 minutes of a GP or a mental health professional on a weekly basis, but it is quite determining. I'm very pleased to say that, and this could also draw your interest, it's one of the online resources for young people with so many different languages, and we worked very hard last year to get the Ukrainian version up and running as well. So if you're interested, you can obviously get back to me and people in the team. There are a number of randomized control trials, so the very specific evaluation studies done in a very independent way. And you see the very encouraging outcomes. This is just one example of how it was done in Hungary, but it has been done in Portugal, in Germany, and Spain, and some other countries as well, with similar outcomes. So you see, no avail, not using the I-5 depression doesn't result in any improvements or changes. Using I-5 depression without the specific guidance does already show significant improvements, particularly in symptoms of depression and also suicidal ideation. But having that additional support by telephone further increases the important impact. And this is just an example of one country, but it's very consistent across many countries. I'm just watching time. I think I'm doing okay. I think, yes. Yeah, so some of the updates here may be new, or at least some new findings and new insights, and we keep working very intensively together with our national partners as well. So with regard to the National Self-Harm Registry, we have a very close link with the National Clinical Programme for Self-Harm and Suicidal Ideation, also in working hand in hand with our training resources. Whereby there's an increasing youth focus as well. And the Connecting for Life, so Republic of Ireland's national strategy to reduce suicide, we have a lot of collaboration, but so many collaborations also here with people in the north. But I think on the basis of some of these examples, I think we could and we should expand this. Just to highlight again, and I don't know if Siobhan, in preparing the program, had a look at Live Life, but again, when I look at the excellent program of today, I thought all the components that are part of Live Life are part of your menu, your program today, which is absolutely great. And it's not a coincidence that WHO highlights these interventions, because these are obviously interventions supported nowadays with significant evidence, but also if you're interested in how to approach the implementation, WHO has given very good insight in how to implement some of these important interventions. I'm just thinking, in terms of time, because I don't want you to miss the testimonials. I think we have until. What I will do is I'll highlight a few points, and then we go to the video, if that's okay. Yeah. So, in terms of suicide clustering and contagion, some of you here may be thinking, or you may have thought, that suicide contagion is something of the current times, that is really related to the fast-speeding social media. It's not. We probably can go back many centuries, but the furthest away we can go, or at least based on evidence, is 1700. So whereby only based on a book written by Goethe. So it was about the suicide of young Werther, where after publication in Germany, and the book was step-by-step spread, not as fast as current social media, but step-by-step, similar cases of suicide were detected in other European countries. And going into small detail here where you think, is that important? But I think every detail is usually important. But some of the cases of contagion of suicide in other countries show that the other young men who died by suicide were dressed in the same way as young Werther at the time of suicide. You can say, why is that important? That's very important in terms of the further evidence of contagion, or at least mimicking a certain situation. So if you hold on to that, because we do a fast forward in a few minutes, then again, when we go more to the quantitative times, so the 60s, but after the death of still expected suicide by Marilyn Monroe, that was in early August of that year, but by the end of August there was a 12% increase in suicide, and particularly amongst young women. And then another example, in 1988 there was, so ethically that couldn't happen nowadays anymore, but there was a TV film in Germany of a 19-year-old student who jumped in front of a train, and there was a 175% increase in railway suicides in young men in the 17 days after the broadcasting. So there you could say that's not a coincidence. There are links, and you could say obviously this is not ethical, but that was obviously at the same time the major challenge. We are fast forwarding, just one of many examples, and I know earlier today there was, I think, also a session on the media, but when we talk about particularly the harmful effects of inappropriate, detailed, sensationalized media reporting on vulnerable young people, that goes without saying. That evidence is unfortunately very robust. So this is another important example whereby the German goalkeeper took his life in 2009. And already in the 3 weeks afterwards, there was an 81% increase in railway suicides in Germany. So there was no coincidence, because we can compare it to the average rates even in a few years before. So I think it's not about whether there are effects, it's now about how can we prevent these effects as much as possible. All of you obviously know the times of Netflix. It goes back a few years. The only reason why I wanted to highlight it here is the ongoing consistency of suicide contagion after very detailed exposure and portrayal of suicide in any media, whether it's social media, the mainstream media, or a movie or a film on Netflix. And going back again to 1700, in some of these cases, there was also evidence that copycat cases of suicide following the exposure of the young girl who took her life in the Netflix series 13 Reasons Why. In some of the cases, and I do remember there was a case in Austria whereby 2 girls had arranged a so-called suicide pact. So they had agreed to take their lives in the same way as the actress on a certain date. But interestingly, they were both dressed in exactly the same way as the actress. So again, that really highlights that very important impact of contagion and mimicking the case of the person who has died. When we think of 1700, and it was not at all in a kind of a funny way, but when I said media dissemination didn't go that fast as what we see now, of course, social media goes very fast, but also, to some extent, it's a lot out of our control, because when you think of something, a series like Netflix series 13 Reasons Why, people can sit down and look at it in a binge watch. They can look at the series just in over a couple of days. And again, that wasn't possible going back a number of years. And that could further intensify the possible negative impacts of that exposure on particularly young persons who are currently vulnerable. Then, step by step, there have been some international resources to give guidance as how to respond and how to improve preparedness, responding to suicide, contagion, and clustering. I think that's really a must. So I think linked to national suicide prevention strategies, there should be regional response plans whereby there are multidisciplinary teams who can respond when there are indications of suspected contagion or suspected clustering. And interestingly, also, when I'm here now in Belfast, and obviously I'm starting, when I think back, I think, yeah, I'm getting older as well. But I do remember, I think, going back to the early 2000s when there were suspected suicide clusters in the Belfast area. And the first person I was in contact with was the priest, a priest who had become worried about possible contagion or clustering. And usually it was only the priest. So obviously, again, in terms of building capacity and having a multidisciplinary response, I think we have to move on from the times where only the priest was responsible for responding in those very challenging and very difficult situations. Because of time, I will move now to the testimonials. But before I do that, again, Kevin Hines. So another key message, I think, for today is that if we take very seriously the process of ambivalence, and you really have to reflect on this. So if you interview thousands of young people, and yes, there's about 65% who reported a wish to die, but never as a standalone motive. So that whole ambivalence is definitely something we should grasp, we should work with, and we should be much more proactive about. So I really think that also supports the evidence. It's a statement of Kevin Hines that people who attempt suicide don't want to die. What they want is a different life. Now, that may not always be easy, but it is definitely a very important pillar under supporting our proactiveness and interactiveness in engaging with people who are suicidal or who have engaged in self-harm. So I think there will still be some time for questions, but I think I give you a few insights into young people. I give the word to young people themselves here, and I may need a little bit of support from the technical team.
Counselling has helped me more than anything, because it was kind of like essentially it kind of brings you out of it during the counselling, and that's why talking is such a big thing, because you mightn't think it then, but when you do talk, you actually find that the cloud slightly starts to pushing away, and then before you know it, you might actually feel okay, and then you're in a state of mind to actively maybe form some new habits, practice new things, such as mindfulness, such as, anything else that helps.
If we want to save the people of this country and make a real change, I think the change has to be big, and the change has to be bigger than over 20 years. Like you said with AIDS, an influx of money, and this is I've been studying it as part of my thesis, an influx of cash came, treatment methods came, and then over a space of about 15 to 18 years, massive change happened. But I don't know if we have 15 to 18 years when it comes to mental health in this country. policy making process isn't built for radical change. It isn't built for someone to walk up, put a proposal on the table and say, we're going to change the way education is done in this country. We're going to put a strong focus on mental health. We're going to explain to every student in the classroom that every one of you have mental health. Some of you will just struggle with it. Some of you will need professional help. Some of you will need medication. Some of you will need to understand to engage in activities and change your food. And some of you will just, time to time, get a bit down. And, you know, and to normalise that, and, you know, to make people understand that, and that's a huge change to take in an education system. And our policy making system in this country isn't made for huge change like that.
The help isn't available for everybody. The public sector, it's extremely difficult to go get help. There could be long waiting lists. Maybe you're being told you won't be able to see one for 3 weeks, 4 weeks, 6 months. I don't know what the waiting lists are. So I definitely recommend talking to someone, because 3, 4, 6 weeks is a long time to feel how you're feeling. So 100% open up to somebody. It's not easy to do. I know that. I'm not preaching and saying everybody should open up. It's going to help you. I lived it for 12 years without saying it to anybody. So I know how hard it is to talk. I know how difficult it is to get the courage to say it to your best friend. But maybe it's not your best friend you have to say it to. Maybe it's a teacher, a colleague, a rugby coach, a soccer coach, or a girlfriend, or somebody you don't really know that well that you see the odd time. Or maybe it's ringing up Pieta House, or Aware, or Reach Out, or Jigsaw, and saying it to somebody over the phone that you don't know, because it might help you. I don't think it's going to make you worse, but I think it could really help calm you down until you're able to go see professional help.
It is absolutely possible to live a happy, fulfilling life, even if you're in the depths of shit, because there are particular things that got you there that are not your fault, that are just how things were, how you survived, you know. But those operating systems can be let go and changed, you know. So that's the main thing, really.
It could have been possible that if I'd known what to do, you know, when I was younger, about where to go, that I would have been able to, you know, keep things from kind of running away and becoming more and more stressful and kind of more of an ordeal for myself and other people.
Like in school we have CSP, we've got religion, we've got art, we've got whatever classes we have. We don't have a kind of a well-being class, where I think we should, from a very early age, from the age of like second class, repeat it again in sixth class, repeat it again in second year, repeat it again in fourth year, where we teach people coping skills, we teach people that it is okay not to feel okay, we teach people what it feels like to have depression, to have suicidal thoughts, because that way those that are suffering will learn that it's okay, it'll be normalised for them, and those that aren't can understand how to help it.
Like even if we were told the signs of anxiety, it probably would have helped, because I would have just been like, oh, that's what I'm feeling every single day. Maybe I should say something. Do you know? Like, very simple things could be done in that regard.
I really reckon I never would have attempted suicide if I was educated on like how to manage my own mental health. I reckon I never ever would have reached the point of attempting suicide.
Why was it so difficult for you to, even while making a documentary with mental health, open up about your own mental health?
2 reasons.
But I also have to watch time. I very much hope that I have been able to convey some hope via my update, but very much so by the statements of the young people. So thank you very much.
Oh, that was fantastic. Thank you so much. Again, we're just going to have time for 2 questions because we have to get to the next panel. Just this gentleman here and one at the front. there one over this side? Want to be fair? Go ahead.
Hello, my name's Harry Collins. Here's my question. Will you say how in TV and film, when suicide is put on like a TV or film, it can have a negative impact on society? Well, I'm not sure if you're aware of this, but a few months ago, a film came out called A Man Called Otto, where it featured an elderly man who was going through suicidal thoughts, who attempted to kill himself multiple times, but failed each one, and in the end, he found a way past his mental illness. But he did die in the end, but that was purely of natural causes and not by his own efforts. So would you say, and at the end of the film it says like there was support from people who are mentally ill in the USA, etc. So would you say that is the one kind of film that's more have a positive impact to mental health, specifically suicide, or would you still think it has a negative impact?
Thank you for raising that. And obviously we got a lot of questions when the film came out, and we were also asked by the National Office for Suicide Prevention to prepare a briefing. So it's about a man called Otto, eh? Yeah, so now this movie is obviously not directly focusing on young people, so I would expect, let's say, a slightly different impact compared to 13 Reasons Why or some of the more youth-focused films. However, we did express our concern because when you look at people who are currently fairly stable, they don't have severe depression, they can balance the perspectives on looking at those scenes where somebody tries to take his life, and repeatedly, including the methods. But people who currently look at the world with very dark glasses, so who have serious depression, these people may not even see the humor, because there was a bit of humor obviously also in the movie. They would focus like a magnet. It works almost like a magnet. They will focus on those specific scenes, and there could still be that negative impact of contagion. So you could say that may be a relative minority in the population. I would say whether it's a minority or not, we have to be responsible when we put out those scenes or those portrayals. So I would be concerned about a certain group in the population. Yeah.
Thank you. Yeah. Any other questions? There's just one at the front here. Yeah.
Thank you. Hi. So obviously, I have a similar question to Harry about the sort of social contagion theory and mimicking of suicide. Do you have an opinion on how good representation of suicide would come out? Because obviously there is a need for awareness. How it would be portrayed, good suicide that wouldn't cause this social contagion effect, but would still spread awareness towards breaking down stigmas and without normalizing, sort of like what Dr. Cooper said.
No, it's a very good question, and obviously it would still require a little bit of debate. But it reminds me of the debates with the branches of Netflix when 13 Reasons Why came out with a group of colleagues internationally. We try to communicate the messages of balanced media reporting, but also we try to direct them to relevant resources such as the resources of the Saving and Empowering Young Lives. But they radically ignored that, or they sometimes said that's maybe more scientific. It's not the case, because we have very engaging training programs and discussion sessions with young people in absolutely in lay terms. It became clear that money was the motive, and sensationalism, but you know, sometimes as a researcher I feel a bit like a detective. They also kept referring to the book. Oh, they said, but the book is there as well, so why can't we do the movie? But I said, you deliberately changed the scene of death in making it more graphic and more sensational and more lethal, because in the book of 13 Reasons Why a person is engaging in an overdose, here, I'm not going to repeat now necessarily here the method, but it's a very graphic and a very highly, so it was clear that money was the motive. So with colleagues like Nev Kapoor, Keith Houghton, we wrote to the different branches, but we were on the losing end. So we still have a long way to go. So there, as I said, there are other resources out. I'm all in favor of awareness, but in a balanced way. And we can discuss methods as well. But it is important to then verify, does it trigger anything with anybody? And to really make sure that there are debriefings about that as well. We can be very open without necessarily showing how somebody dies. Yeah.
Thank you.
Yeah.
Thanks very much, Professor Arnsman. We really appreciate that presentation today. Thank you. Thank you so much. I'm going to ask our panel to join us on the stage now. We have Professor Siobhan O'Neill is back with us, Kuli Suma, the Northern Ireland Commissioner for Children and Young People, Caroline King, Area Manager for I knew I wasn't going to be able to say that. Papyrus, and Inez Murray is going to rejoin us on the stage. Lovely. Thank you. So we're specifically in this panel going to talk about policy priorities for youth suicide prevention. Each of you can decide whether you want to sit and chat here or if you want to deliver what your thoughts are at the podium. But Siobhan, do you want to go first?
Okay,
or do you want to go at the end?
I can, yeah. No, it's not supposed to be about me talking, but we do have some really good plans. But so we Protect Life 2, the suicide prevention strategy. We need to keep implementing the stuff we have in there and fund that fully. And we're still about 2 million short every year for that strategy. But I think there's elements that we could add to the new iteration of that strategy. And I have a lot of ideas today, especially youth-led services, neurodiversity, how we address LGBT suicide. So there's self-harm care as well. I don't think we're doing that at all well, and I'm even more convinced of that following today. So there's that. There's the independent review of education, which is my great hope, and the only way that we're going to get the changes, the fundamental changes to our education system to reduce academic pressure. Sorry, am I taking your ideas? So there's that.
I have no hope in the review of education.
Yeah, well. but that's, and then as a population we need to demand the changes then from the ground up if we're not going to get them that way. Policy priorities, a full programme for government that emphasises well-being, reducing adversities, reducing inequalities, all of that stuff. Let's make Northern Ireland a nice place to live, and fewer people will want to die by suicide, including young people. So those are my ideas, but I want to hear from everybody else here so that I can...
I think it's good to start with you though and kick that off, and we'll hear from you again at the end. But Kula, I know, we're literally on the countdown here in terms of your role as Children's Commissioner, but I think it's fantastic to have you here today because it's the culmination of the year's work, and Siobhan mentioned the Still Waiting. I was there in 2018 at the launch of that as well. So, what do you think are the kind of priorities as you leave this current office? What would you like to see coming behind you now?
Thanks, Tara. I think Siobhan's right. I think we've got the seeds, the green shoots of hope, or whatever you want to call it, about doing things differently. I suppose just some of the things I want to tease out. So we talk about youth suicide prevention. I think we need to remember children are different from young people from the point of view of the definition of under 18s. So we're sometimes talking about different systems that kick in. You already talked about education, but also social services, as child and adolescent mental health services. So as somebody who's stayed with a young person who's now 21, the adult system is incredibly different from the children's system. So we need to be mindful of that when we're talking about suicide prevention. I think some of the things that came out of Still Waiting, and government are still working on it, and Siobhan, has taken on the mantle to continue to try and make that happen, is partnership and upstream. I hate that, upstream, but shift left or whatever we want to talk about, is that the voluntary and community sector and the statutory sectors are in partnership, should be working in partnership together. We know that if on children's sides, it takes a long time to get into CALMS, and sometimes CALMS isn't always the right thing for you. Whereas if we were having a better early intervention and prevention models, if GPs were more confident that they understood what was going on in communities, then they could refer that way as opposed to just that way. And the other thing, and it came out in the film, is one size doesn't fit all. You know, what came out in our Still Waiting when we talk to young people, that I will want to talk to different people. So maybe people in school, it may be my youth worker, it could be the dinner lady. You know, so the importance of making all of us as adults, whether we're professional, in whatever capacity we have in a young person's life, that we're ready and that we're confident in having those conversations, and that was very important. And there's a big shift about moving a lot of our well-being and mental health, early intervention, mental health first aid into schools, which I thoroughly support, but it can't only be in schools, because a lot of young people saying, I want school and what's going on for me to be two separate things. A lot of other young people going, I'm really happy that it's in school, because again, we heard, I'm learning about it and I can go and it triggers. So we need that, you know, that different environment. I'm going to shut up in a minute. Well, no, I'm not, but I'm going to.
No, please don't.
We also need to quality assure the programmes that we are, I'm going to use the word inflicting on young people. I don't mean it like that, but I'm old enough to see what different phase. So we do at risk and we do employability in the phases I've seen, and now we're in mental health, which means people come in, not obviously no one in this room, but people come in for either for the quick buck or because they need their own service to survive. I think we need, and this is something we've talked a lot with Siobhan about, I think we need to be sure that the services that our young people are receiving in this space are quality assured and are robust. Otherwise we're going to do, and your work has proved that, we're going to do more harm than good to our young people, and we need to stop doing that. I could go on and on, but the one last thing is no wrong door. You know, whatever door a child, again, like in my case, a child goes through, should be the door they receive the help. If the person just behind the door can't do it, they should know exactly and take them to where it can. Too many doors are closing in young people's faces because they're told, not right for you, or you don't meet our threshold, or you're not acceptable. And they feel like they're starting all over again and back. And parents get really, really worried and sad and upset. So that we need to be genuine when we talk about the no wrong door approach to services for children and young people. That's just a few of my top tips.
We'll open it to the floor in a minute, but I just want to hear from each of the panellists. First of all, Caroline, I mean, Cula's touched on a lot of things that were raised this morning as well, and Inez, I'll come to you on some of those as well, particularly around criteria and whether people reach that threshold to get a service and just how services are delivered. But from your point of view, Caroline, what do you think we could be, what are we doing well, where's the best practice, and what could we do better?
Well, for me, working in the community and voluntary sector for 16, 17 years now, and working in this field, I would say, like, we do a lot of really good things well. You know, and you know, this conference is called Generation Hope, and I have to say, like, we sat here today and we listened to the next generation having a conversation with us, and for me, there's loads of hope in that. There's, like, for me, that is the way forward for us. We have to have these conversations with young people, and not just, you know, a lot of us listen to young people and the work that we do in our homes and our society. We listen to young people, but it's the action that we take after that. You know, we need to act on what young people are saying to us. You know, it's not good enough to just sit there and say, oh, you know, this is great. You know, this young person told me their story. You know, that's a very privileged thing to have, is to have, you know, a brave young person stand up and say, this is my story and here's how you can help me. And we've got amazing organisations across Northern Ireland doing fantastic work. Amazing. So for me, you know, as Papyrus, that whole schools approach is really important for us. You know, it's the dinner lady, and who gets the high five every morning? It's the lollipop person. Do you know what I mean? Those are the people we need to equip. A big part of our programme is about equipping the adults around those young people. So we need to be careful about what we put into schools, but we also need to be ensuring that the people around young people have access to high quality training and support, so that they feel confident to have these conversations. The biggest thing for me with adults is that We're terrified of having conversations with young people. And anybody in this room, by the end of this day, that doesn't know that young people are having these conversations, haven't been listening. Young people, we say, let's not talk about sex. Let's not talk about drugs and alcohol. We shouldn't talk about suicide prevention. But actually, young people are doing that anyway. They're having these conversations. We need to create safe ways for those to have those conversations. So for me, we're in this circle of prevention, intervention and postvention, and it is a circle for me. It's not a new wheel. You know, we can't reinvent this. You know, this has been happening for a long time, and people don't know they're in that circle because good postvention is prevention. So, you know, for me, when we're talking about policy, we need to join that circle up and have lots of little doors and gaps and spaces where we can let other people in. You know, we let drugs and alcohol in, we let eating disorders in, we let everybody in that has a say and has something that can add to this conversation. But for me, you know, when we create new policies, it's not just about listening to young people. It's about taking their ideas and making them happen. So policies shouldn't be things that sit on shelves and get dusty. They should be things that we actually enact.
Brilliant. Thank you, Caroline. Inez, I think you know, most people will go away from today having listened to yours and your colleagues, peers' stories and thinking, ooh, how could we replicate that all around every kind of town and village? Is that a vision that you guys have? Is that what you'd like to see happen? Crisis cafes everywhere?
I think so. I would love to have a crisis cafe in every town, every city. I mean, since coming to university, you do really miss it. It is far away, but it's always just a text away as well. And I think when we're having these conversations, we have to look at what is already out there and what is already working. And from listening to the young people today, the methods like Crisis Cafe, they work. So why not introduce them more? When we're creating our policies and looking at our priorities, they have to be youth-led. We have to listen to young people to see what has worked and what could work and implement that. Like you say, it's okay to listen for a day and say, that was really nice. But you can't leave this room and just walk away and think it was a nice story. These are young people's lives. They know what works, so we need to listen to them and implement that.
We open it to the floor. It's a bit brighter where we're sitting out here. There's... Oh, yeah, someone, yeah, just in the middle there.
Hopefully everybody's not too sick of hearing from me, but I kind of just really thought the terminology, as we know sadly a lot, when a young person dies by suicide, that they've committed a crime and that they're kind of leaving this kind of crime legacy and stuff behind them. And kind of my question is how do we structure and conduct young people, because as was mentioned that a lot of professionals are quite terrified to go and speak to young people because they don't know how to best approach it. They don't know, okay, am I going to say something that could then have a lasting impact or potentially then could have a young person take long life. So is it a need to actually look at terminology and how we're actually addressing people? Because as we've heard from many young people from Crisis Cafe, that the young people, they're starting out their lives, they're starting out their stories, but sometimes they're not being listened to. Is there a terminology or is there a way that we can better equip professionals and help better kind of train and educate those to then be able to have open and more honest conversations about suicide?
It's a really good question. I mean, I know Samaritans. I'll come to you, Siobhan, if you don't mind, because I know they've done so much work, and I was at the session today and I was involved in the guidelines many, many years ago in terms of that kind of the crime thing. It's interesting to hear a young person talk about the crime because that to me feels very much in the past. That, you know, I know in the BBC we stopped using the term commit suicide because family groups came to us sort of 15, 20 years ago and said we don't like that terminology because it does harken back to a time gone by where there's a kind of criminal element to it. So it's interesting that that is still an issue, and I suppose those terminology things, that is just a process that's ongoing with organisations like Samaritans.
Yeah, I mean, well, just to talk about using the word commit, I mean, the last thing we want to do is silence the discussion is put people in their place when they're starting to talk about suicide. And we say, oh, you've said the word commit, therefore, you're kind of protecting that territory and excluding people from it. We all need, I think, more skills in terms of how we talk about suicide, and there needs to be leadership in terms of this as well. I think in schools and communities and sports clubs and all those places, there should be protocols sitting there and a pre-arranged policy around what happens if there's a traumatic event, as we saw last week, or a suicide death. Who's going to take responsibility? Who's got leadership? How do people communicate there so that that doesn't have to be created on the spot after an event? I think that's really important. And then there's lots of really great training and resources available. Papyrus have resources, Samaritans have people there. So I suppose it's about knowing where to go and having that leadership and having the policies in place, but not trying to exclude anybody from the conversation and not getting too hung up on words and phrases. It's just good that we're talking about this stuff and gently, slowly and gently getting the message out there that how we talk about this stuff does make a difference to what people do when they're in a state of crisis. So those are some thoughts. But I think Papyrus have some great toolkits that you might want to tell us about.
We have, we have a set of training that's really good. Like we have an hour and a half training that really helps people formulate that language around what's useful language to use whenever you're having this conversation. And we bust a lot of the myths when we do that training as well, to kind of sort of say, it's okay to say the word suicide, because it's not going to put it in somebody's head, that it's not going to make, people go, oh, that's a great idea. It's actually having the ability to encourage people to feel confident around having this conversation in a way that supports people to think about, the relief that you get when somebody says to you, are you thinking about suicide? The relief that comes over you to say, actually, yeah, you know what? That's what's going on. Or, don't be so daft, I'm not thinking about that, but this is what's going on with me. It opens that conversation for someone. So yeah, we have training and we've lots of free resources on our website that you can download. But I just think, in relation to language as well, it's really important that we get in alongside our media and get in alongside our parents and get in alongside our teachers to support them, because, in a world that we're living in today, like we have young people, like I'll not say the name of the big social media giants, but we know that social media often will exclude us from using words like suicide. Even us, a suicide prevention charity, like we'll go on sometimes and we'll try to promote suicide prevention, but they'll exclude that post that we put up because it says suicide in it. So algorithms don't think about what's right and wrong; they just plough on. So young people are being creative around getting around that, using things like undead and language that, they can have this conversation with each other. Now, I'm not saying that we should support, getting around that conversation, getting around that language, but what we should do is look at how do we create platforms for young people to have safe conversations. One of the things we do on our helpline is that we have email, text and chat. So young people, particularly young men, find it very hard to do this, lift the phone and have this conversation. It's challenging. As you were saying early on, walking in the door for the first time, having those conversations for the first time in Crisis Cafe, it's nerve-wracking. But when you can do this or this, it just makes it a lot easier. It takes the pressure off. So we need to meet young people where they're at and have those conversations with them and talk in the way, use language that's appropriate for them and what they're using for us. Ask them, what's the best way to talk about this?
I just wonder, to bring back, because I totally take your point about young people sort of saying, oh God, can I not just be in school, and then if I need to go and seek help, I'll do it outside. Obviously, there'll be other kids who will want to access it in school, but is there a problem with the kind of standard across the board? So you have some schools that are doing amazing work and they're kind of forging ahead and they're using organisations like Papyrus to do that, or Samaritans or Lifeline or whoever it is, and all the organisations that are represented here today. How do we get all schools to be at that level?
So there's a massive issue about consistency and like I said, quality. Just before I answer that question, because I do want to sort of also talk about Cruise and Lighthouse. It just feels like everyone's being named, but I know Lighthouse have a programme around children who die through suicide or at their own hand, and going in and supporting their peers as well. And there is something about keeping that, having that in the plan, so you're not scrabbling around when it happens unexpectedly. Because it's always unexpected, that you've got a plan. If this happens to us, we know what to do, and we've got it in place. So yes, the issue is. So I'm hoping the educational, the well-being in the education and well-being in schools framework, whatever it's called. I always forget what it's called.
It's not mental health. It's definitely not.
It's not. It's emotional well-being. It's emotional well-being framework in schools. I'm hoping that will begin to make sure that every school in Northern Ireland has at least a nurture room, but somebody qualified in the nurture room to have those conversations. That does what again was talked about in the video, but what we know children and young people want. Has some sort of lessons or class. I always think LLW, Learning for Life and Work in post-primary schools, we need to take the exam possibility away from that and make that a far more inclusive curriculum, including LLW and obviously relationship and sexuality education. So there is a huge piece that we need to do. We need to make sure, as we said, we have a proper training programme across, because school will be the place. It often is the first port of call. We learned during the pandemic, we've seen our child protection figures go through the roof, and our children in need and our children in care figures go through the roof, because when we closed our school doors, we also closed the early intervention and early warning mechanism that we have in Northern Ireland and anywhere in the world, where schools, teachers and other school staff can see when something's changed in a child. And if we work properly in partnership, they can pick up the phone and say something's going on with Wee Johnny, or say to Wee Johnny what's happening, and get even services in schools. So the schools are a huge prevention and early intervention mechanism. And we learn to the cost of many, many children and outcomes for them, what happens when we close schools. So absolutely, but the quality, I'm not 100% confident of the quality of some of these emotional well-being and mental health services going into schools, and that's really, really worrying me.
It's a big consideration. I mean, it's maybe something that Crisis Cafe may well look at, or if you're not already doing that. Yeah, absolutely.
There is some evidence that some of the interventions that have been used in schools can increase symptoms.
Okay.
And young people, yeah. So, and so the evidence is starting to emerge. It's why it's so important that we keep doing research and we analyse every outcome and every programme. So and we only choose the ones that have... that we know that will have the right impact, and also that there's that wraparound support, because there's nothing as bad as going in and getting a great programme and then everything else about that school environment is harmful and toxic, and then the contrast there can actually have a net negative effect in some ways, so it's got to be about moving forward across society, but across the whole school.
Yeah, I mean, somebody touched on that earlier, saying that, the mental health was in place and there was some support offered, but then another teacher came in and said, yeah, but you need to get your GCSE results.
Why you miss class?
Yeah.
Well, because I was at the counsellor.
But you can't miss class.
Yeah.
And so what happens if I need to go to the counsellor so that I can actually manage my classes and I can participate in education. But if I'm now being told I'm going to fail my exam, or I'm going to be left behind, or I'm being labelled because I'm going into the school's council, then it's even worse. So it has to be, Siobhan, as always, is always right, has to be a whole school approach. Caroline, you were going to come in there.
Yeah, no, and I think, like the whole school approach, like that's our bread and butter, is what we do. But I think one of the things for me is that, schools are really struggling because everybody's banging on the door. And this is why policy and legislation is really important. It's not about saying, we have to have really good schools programmes going on, because we do. Like Lighthouse is an example. Aware have fantastic... there's lots of organisations out there that are doing really good work. But there's other people coming along saying, we're going to run a schools programme, but it's already been done. It's just the fact that there's no standardisation. Schools don't know where to go, so we need to help them with that, and that's policy. When you talk about what needs to be put into policy, we need to have that standardisation, that it's not just a postcode lottery of where you live. It's every school has the same opportunity. Every young person has the same opportunity to access services when they need them.
Inez, did you find that? Do you find that when you're in your time with the Crisis Cafe that people are feeling frustrated, but then by the same token you'll have others who have a great experience? So is there that mixed picture?
There is a mixed picture, but I think one of the issues is that you're right, schools have started to talk about well-being and stress and resilience, but that's not mental health. They're not using the language, like Ethan said, of suicide prevention, mental health, intervention. They need to use those terms, because when I was in school, 3-4 years ago, I was told about well-being and resilience, but no one actually said, this is for your mental health, this is to prevent suicide, and that's frustrating for young people. There's more well-being, but no one's really listening, and like I said, when I was in school, very sadly, someone took their own life, and when we said, let's talk about mental health and make it more available for young people to learn about it, we were told that if we talk about it, they might actually think they have it. And I think brushing it under the carpet, it's not going to work. We need to talk about it, and we need to listen to young people and what they want to hear. Like if the teachers had went to Fergal, like he said, after his friend passed away, and said, well, what language do you want us to use? It would have been maybe a different outcome. You would have been able to talk more, and it could have gone a different way.
No, it's really interesting. Thank you, Ethan. Thank you so much for your question. That was a really timely one. Next up, up at the back there. Thank you. We'll get to as many of these as we can.
Just from a young person's perspective, like in schools, if you were to notice like self-harming or suicidal behaviour in someone else, it's just like, how would you go about reporting it? If not reporting it could potentially lead to normalisation, but reporting it can lead to issues with not receiving appropriate treatment or services. Like, how do young people actively support each other while also following like safeguarding guidelines?
Oh, great question. Who would like to start with that one?
You have to report it. You have to report it. If we're talking about schools and you think a child is hurting themselves or is at risk from same thing, you have to report it. You can't think you can sort it yourself because she's my best friend or he, you can't. You need to be with them. You need to tell them that it doesn't matter what they've done. You'll still always be there, but you have to report it. The other myth we have to bust is that there aren't any services out there. There are services out there. For some services, it takes a little bit too long, but we know with the CALMS that we're looking at holding how if somebody definitely needs CALMS, but the list is too long, what can we do to hold them whilst they're on the, not ignore them, but. You have to report. How many times have I said that? Doesn't matter. I'll say it again. You can't manage this alone. And actually, the only thing you can do is report it because that's the only way your friend or whoever at school is going to get the help that they need. And if something happened, you would feel like it was your fault, even though it's not. It absolutely wouldn't be if you didn't report it. But children cannot experience any harm either from themselves or from other people without an adult knowing about it and without an adult stepping up. If the adults do not step up, then there are mechanisms, my office, Children's Law Centre, whoever, the board of governors of the school, we keep going until the adults step up, and you need to help people like my office to help you to do that. But never stay silent. Never stay silent. Hopefully talk to your friend and get them to come with you when they're reporting. You try not to do it behind their back, but sometimes you might have to do it behind their back because it may be the wrong thing, but we trust your judgment. And we also know, particularly with young men, boys talking to boys is often the way into getting services from adults. I'm telling my friend in the hope that my friend tells somebody else. Although very often what you're talking about is you see something and you think that's not quite right. But please don't do this alone. If a friend of mine was hurting, I'm very old, I would try, but I'm not sure I could cope with it on my own, let alone if you were under 18. So just in case you didn't hear, please report it. So report it to the pastoral care lead in school. If that doesn't work, go up the way or the side the way. Report it to the pastoral care lead or to the teacher or school staff you trust the most. would be my recommendation. And if something doesn't happen, keep going and involve in external agencies if necessary, so that your friend gets the services that she needs or he needs.
In addition to what the very wise Children's Commissioner said, no, honestly, 100%.
What did I miss?
No, you haven't missed anything. But just on top of that, I would add, it is completely okay to phone Lifeline with somebody, to sit there and practice phoning them, or Childline. Those are the two, or Samaritans. Just, this is what happens. Let's just ring them. Or Hopeline? Yeah, I always forget, sorry. Or Papyrus's Hopeline.
Whatever line.
Ring the number with them so that they have that practice. You don't have to go into any detail. It's a, I'm here with X. They've been feeling a bit low. They might want to call you later. We're just saying hello to see what happens when we do the call. And that is, because it's impossible to ring a line just on your own. It can be care call if you're a student. You know, but go through that with them. Phone the GP and ask for an emergency appointment for your friend. I've been in this situation myself. I've been in emergency departments with people. You can do this. They may hate you, but they will thank you later. And it doesn't matter, because you're doing the right thing. You're absolutely doing the right thing. So don't be scared to use all the numbers that are there and put the phone on speaker and do it with them, and be really courageous, because it takes a lot of, guts to do that. But trust me, they will be glad that you've called, and it can break down that barrier to getting help, or send the text with them, or write the email. Just do it with them. You don't have to tell them what to do. Do it with them.
Yeah, brilliant advice. Caroline.
Yeah, can I just say that, I've been working in suicide prevention, as I said, for a long time, and there's lots of people in the room that I can see that have been doing the same, like Gary and the likes, have been around for a long time doing this work. And I will say, none of us do this work on our own. Not one of us sit and do this work on our own. We have colleagues, friends, teams around us. We always have someone around us. So we never do this work on our own. So I just reiterate exactly what Kula and your woman over there have said. And Siobhan has said. Because what I would say to you is, trauma is one of those things where the really important thing is that if you have choices. So when you're talking to your friend, ask them, who do we need to tell about this? We need to tell someone. But who would you like me to tell? Do you want me to talk to your mum? Do you want me to talk to your teacher? Who do you want me to talk to? But we need to tell an adult here. We need to tell somebody, that can get us the right help for you. So ask them who they want to speak to, and then go along with them. And as Kula said, if they say, oh, no, I don't want to talk to anybody, you say, well, you told me for a reason. It might be in your subconscious, but you told me for a reason, so I'm going to act anyway, Because for me, better to lose a friend as a friend for a while than lose them forever.
Well said. Thank you for the question. Inez, do you want to add anything to that, just in terms of your experience? How difficult is it for young people to make that call, or to say to somebody else, even as they've said, it's on purpose, accidentally on purpose, I'm telling you, so that you go and tell somebody else?
I think, and I don't know if Kula mentioned it, but I think report it, definitely. I think, just in case you forgot. But that's so important, because at the end of the day, we are young people, I know, and it's happened to me before. People say things to you and they're not saying it to you, they're saying it because they want someone to listen, and because deep down they know that they want and they need help. And it's important that as a young person, you don't do it alone, because you're not alone. And like Kula said, I know most of the time when we're up here, we're saying how little services there is and how much more investment is needed into them. But there are services there. There is Lifeline, there's Samaritans, there's Papyrus, there's Crisis Cafe, which is available on social media for anyone to message who needs someone to talk to or who needs a bit of guidance. That young people aren't here to do it alone. And if your friend does come to you, just make it clear that you are there to help them on with it, and that there is help out there and there is hope out there. And like you said, it's better to lose a friend as a friend than for a young person to lose their life. But as well as that, take care of your own mental health. If someone comes to you, it's a huge burden as a young person to hear those things and talk to someone and talk through how you're feeling about it. But you're never alone, and I think that's the most important message from today.
Oh, absolutely brilliant. Brilliant question. Thank you so much. There was somebody just behind you. Oh, you've got the mic already. There you go.
Hello. I'm just wondering about your thoughts on progressing the LGBTQ plus youth suicide prevention efforts. We had a session this morning discussing that and highlighting that they were at increased risk. And we also looked at the invisibility of them in the data that's coming through and the lack of information on suicide rates. And then we had a presentation from Ella from the Self-Harm Registry, which very much focused on males and females and girls and boys. And how we progress that to identify these groups. We can't meet their needs if we don't know who they are. And I feel that leaving them out of the research and the data adds to the sense of exclusion and of not fitting in.
No, thank you. Good question. Siobhan, do you want to start on that, just in terms of the research, just from the academia point of view?
Well, I was there for Hazel's presentation. I couldn't agree more. The very first quote you used was from Protect Life, our policy, and it was just the penny drop with me about how completely inappropriate the phrasing was there. So I would like to work with Hazel on the next, and get your views, to be honest. And I've got a PhD student, Emma, who's maybe around today as well, who specialises in this area. So it's about working with the people who know, who can guide us, who can help us, and asking for that bit of help when we're writing policies. I think we need to be including gender and gender diversity and sexual orientation and all that stuff whenever we're collecting data about young people, but we need to do that in a way that's appropriate. And again, this is about going to the young people themselves and asking them how they want us to do this. But we need to start collecting this data, and without data, we won't have the evidence. So, this is something that we need to do better on, and that will be my commitment, is just to try harder here and to engage with the people who know what they're talking about here.
Kula, in some ways, it's it is slightly depressing that is still kind of, that it's not front and centre, because we know, especially in Northern Ireland, that growing up and that coming out and all of those kind of issues that young people are facing now, that our adults who were the young people of yesterday faced in terrible circumstances. And your heart breaks when you think back to some of those stories, but it's slightly kind of irks me that is still an issue, that we still have, we have a question like that from the floor.
Yeah, and it's still it's still a big issue, particularly for our trans young people. I think that's where the issue. So it goes back to what I said about relationship sexuality education and about making sure that we have inclusive processes. So one of the things that we I haven't mentioned, but something called child death overview panels, understanding why our children die, particularly when our children die of avoidable deaths. In Northern Ireland, we have the highest avoidable deaths. In 2019, we had the highest avoidable death statistics of any of the 4 jurisdictions in the United Kingdom. And so we need to understand every single one, because it's not thousands of deaths we're talking about. So we need to understand every single one of those deaths and what led up to it. And the fact that we do have a bit of law that was passed in 2011, that said that we should examine every death to look at if there's anything we can learn from it. And yet here we are in 2023 and we still haven't implemented it. And here we are in 2019, I'm not sure where we're at 4 years later, the ONS haven't reported on it. We still have the highest levels of avoidable deaths amongst children and young people. So we do need to see every single child who dies, regardless of how they die, particularly if their death is attributed to suicide or an accident. But no child should be invisible. No child should be voiceless. No child should be unheard. The only reason is because we ignore them. And this is, again, goes back to a uniform approach across our schools. It's left up to schools to make individual choices around certain things because of this thing that there is about in accordance with their faith. Faith should never get in the way of equality. It should never get in the way of non-discrimination, and it should never get in the way of making sure every child has their best interest taken into account. So I've been packing up the office. That's why I'm a bit stressed. I haven't been stressed saying goodbyes, but packing up the office has made me very stressed. But I have left a folder for the new commissioner around trans young people in particular, to think that's the piece of work. My office hasn't done as much as we could have or we should have, mainly because, for various reasons, but no government. I wasn't sure where the conversation was going to go without government. With a government, I think we're going to have a GRA in Northern Ireland, and we need to bring this issue front. I'm going really big now. We're going to bring this issue front and centre, but I completely agree we should see every child and know why. But one of the things we're fairly sure around LGBTQ+ is that because we don't value them, we don't see them, we don't allow them to be who they are. And I don't have an issue with any child wanting to identify in the other gender, and nor should anybody else. And we should help them go on that journey with them and see where that takes them.
Thank you.
Gender Recognition Act is
Sorry,
GRA.
Caroline, I'll come to you in a sec, but Inez, I just wonder, is there anything you want to add on that from a young person's point of view? Is that still an issue? Is it around trans, as Kula says? Is it still around, gay and lesbian? Are those groups feeling underrepresented?
I think they are, and I think you only need to come to the LGBTQ awareness group at Crisis Cafe to see that, although it is closed for the community, of course, so that it's representative and safe. But LGBTQ plus young people, they do feel underrepresented and they don't really feel listened to. I feel like Dr. Moretti said it so well in her research that we need to listen to them and we need to qualitatively assess what they're saying, because sometimes they say, well, is my sexuality and my gender orientation separate to my struggles with my mental health? And we need to listen to what they want. I think that's at the core of it. We can't just assume what they want based off media reports or things like that. We need to actually listen to them and go to them and ask them what they need. And I think, like Kula says, we can't let things like faith or schools' own preference on their syllabus or curriculum get in the way of children and young people's mental health, of them feeling accepted, them feeling loved and them feeling wanted, because every young person in Northern Ireland has a place and they need to feel worthy.
Yeah, and I mean, you raise a really important point around schools and individual teachers that can make a moral judgment themselves and kind of inflict is probably not the right word, but to sort of put that onto their pupils, or to exclude something or exclude a discussion or a particular play or a book or whatever. Caroline, is there, where does the voluntary sector come into this particular argument, do you think?
I think we lead the way sometimes in this conversation. We have there's not a volunteer or community organisation that I know out there that aren't supporting young people in the LGBTQ plus community. This is not an issue for community and voluntary sector. It's one of those places that the majority of organisations that are working there say it is safe. And we do a lot around promoting on our socials and all of our sites and all of our services to say, look, it is safe for you to come to us. But I think it goes beyond school as well. I have to say, I know we've talked a lot about school today, but we have to think about young people who start off into employment as well. And we have a society that sometimes the leaders of our society, when they take office every now and then, they say things that are so destructive to young people in this community. There's times where you sit there and you think, gosh, if they had their way, I'd be off in Boffin Island or something. They'd just be taking us and putting us in some random place and locking the door. So it's very uncomfortable when you hear the leaders that are saying, actually, we don't think you should have the right to marry, and actually we don't agree with gender-neutral bathrooms in schools or whatever it is that they're saying. So it goes beyond school for me. I think, we need to look at employment, we need to look at our politicians and our civic leaders. And now that's not to say that we haven't got people that are putting that voice out there, but we just need to be very, very clear that, young people who are in that community who die by suicide often don't die because they're LGBTQ+. They die because of the discrimination that they face. Exactly. And that's not good enough.
Thanks for that question as well. Yeah, we'll take two more. Just one here and one there. We'll see how long it takes. I'll just go way over and then get into trouble. Go ahead.
Seriously? Seriously going to ask a question? Gil used to be my boss like 3 months ago.
So Patrice, I'm Nexus now, not Nikki. So we support children and young people from 4 years old who've experienced sexual abuse and abusive relationships. And I suppose this is really about the prevalence study and how effective you think that is and how reactive to trends that is. I'm thinking specifically the Centre for Disease and Control this month. They come up with the stats around 1 in 5 experienced sexual violence in the past year. And that's people who took their own lives, by the way. And 1 in 10 were forced to have sex. So very specifically about sexual abuse or sexual harassment. Does the prevalence study cover that, or can it be adapted to do that, or is it just a gap?
Wellbeing prevalence study, you mean?
The well-being.
Yeah, the young people's.
Yes.
It's included certainly as a childhood adversity.
Yeah.
I would need the report in front of me for ongoing issues, so I'm not sure. I suspect not. But yeah, it's certainly in there as one of the childhood adversities that was studied. But we need to implement the Gillen review. We need the violence against women and girls strategy. We need mandatory RSE in schools that's inclusive, and all of that would help to drive this stuff down and change our thinking around consent and healthy relationships.
And as you know, with Gillen, particularly for children and young people and sexual abuse, Nikki's hitched or whatever to the Barner House model as a way of intervening, which is a way of separating a child's healing process, separating it from the criminal justice system, securing the evidence, letting the child do what needs to be done in the support. And if we did have such a model, whereas at the moment the model is, particularly if the person who's hurt the young person is known and they're in the criminal justice system, children can't go on that journey of counselling or healing because of the risk of those records being subpoenaed for the trial. And used either to challenge the child's story or to whatever. Whereas if we had a Barner House model, which, like I said, secures the evidence within 24 hours and allows the child to heal, and that's them out of the criminal justice system because the evidence has been forensically secured, is the way. And you would hope that, I mean, we'd have to look at compare with the countries that do have Barner House, Iceland in particular. Don't know where they were on that list, Iceland in particular, to see if that would help prevent deaths by young people who were victims of sexual assault.
Yeah. Inez, do you find again, that's a question that comes up, that that kind of trauma around sexual abuse is something that's quite prevalent in the Crisis Cafe, or is it just one of many?
Well, I think this is something that I wouldn't personally be privy to, because I feel topics like that would come up more so in the one-on-one conversations with people like Louise and Grania in Crisis Cafe. So I can't personally speak on that, but I think it's just one of a range of issues that young people are dealing with. And I feel like you're right, it can't just be the criminal justice system dealing with the child themselves. The young person needs support when they need it, and we need to make it more accessible to them. We need to make them know that there is people there to listen to them when they need it.
Caroline, do you want to come in on that one?
Just to say, if you haven't seen Cup of Tea by Nexus, go and look at it. It's brilliant, and show it to every teenager that you know, because I think it's one of the easiest ways to explain consent to young people. So, go and look it up.
Get that all written down. Thanks very much. Really interesting question. There was somebody else around here, wasn't there? Oh, in the middle there, yeah.
Hello.
Just on
a similar vein. I work at Engage Women's Service, and I'm working in the community and voluntary sector with young people for a long time, and now working with women and families. It was, the statistics looking at how for young women this is becoming more of an issue. And I just wondered about, I know there was a lot of research after what we call the Troubles, which I think really minimises what happened during those years. But there was research that came out to kind of show that women's voices and women's experiences during the Troubles really were lost. And actually the prevalence of domestic violence, gender-based abuse and violence increased. And we know that in the research, in terms of the whole period of lockdown and COVID, that there's been similar trends. And I just wondered, has there been any more investigation into that and what we're doing here in Northern Ireland in order to kind of address that? Because for me, in terms of the lived experiences of the women we're working with, I've attended funerals of women we have lost to domestic violence and women who had histories of abuse and gender-based violence in the last couple of years. And I don't think that that's a coincidence. And I just want to hear more about, how are you taking that forward in your work at the minute?
Yeah, it's sort of maybe slightly outside your area for you three, but Siobhan, is there anything you want to add on that, just in terms of older people?
Only to say that the Executive Office had a COVID recovery plan that they were developing, and I provided really detailed response to the consultation on that, and suggested that all of this stuff happens and that there's a focus on mental health and violence in all its forms, and abuse and neglect, all of that stuff, and very little of it made its way into the recovery plan. And I'm hearing very little about the implementation of that plan, to be honest. Now, there's a lot about the economic recovery side of it, so, but I mean, I would need to get the Executive Office to provide an update on where we are and what has been progressed. So there's a general area about health, but I was quite disappointed. And I haven't heard much there, but I can ask the question again. As far as my understanding goes, these services have been cut further, and it's just not good enough.
Thanks for your point there. Just this final question, then we will make it the final one before we finish. Go ahead.
Obviously, in recent years, there's been a big push that physical health is as important as mental health. And I think it was quite recently that first aid training was compulsory in schools. So my question is, as students, should there be compulsory training for suicide prevention, so that when we have one of our friends comes to us with an issue, we know that we know the right things to say and we know the right direction to point them in?
Yeah, it's a really good point, because what you'll find in most workplaces now is that mental health first aiders, not everybody necessarily gets trained, but a lot of offices and workplaces will have that. Something you would all be supportive of?
Not necessarily.
Okay. Do you think it's too...
It depends. Mental health awareness. How to signpost people and help people get to services that are there. The services do need to be there. Not intervention. We don't want to get into a situation where people can think that they're expert or feel that they're obliged to intervene. And so it's got to be done very, very carefully in the context of a broader network of support, so that when somebody does that disclosure, that you can get that person to help. And also there's a lot of safety issues for both parties. So it's about asking how are you feeling and getting help for that, not asking what's happened to you, and asking people to go into detail about things that have happened or promoting disclosure of very traumatic events. But it's about thinking, how are you feeling and how can we get you the help to explore this, to get treatment if that's what's required. So it's got to be done really, really carefully. And I'm not necessarily in favour of mental health first aid approach in schools, so that you have first aiders as such. I think that's maybe not a good road to go down, and we need to look at the evidence for the outcomes there. What are the impacts? What is the research telling us? In terms of suicide prevention, it's slightly different. Giving people the skills to know what to do if someone makes a disclosure and how to get them to the source of help and know that that's their job done. I think that is very, very helpful. And there's the Zero Suicide Alliance 20-minute suicide prevention training, which I think is quite useful there. So again, the answer is more nuanced and we need more research. But generally, suicide prevention stuff is quite positive. What do you think?
Never ask an academic what needs to be done, because they'll always tell you need more research. But I think Siobhan's absolutely right again. We do need to be comfortable in having those conversations so that we can, your answer to about the school question is, how can I go with you? But I will need to tell somebody in order to get you. So it's about having the literacy, to be able to have the conversation so that we can help that person find the right support, but not to think that we can fix it. So in child protection training, we say, just get as much information as you need so that you can refer on to the people who are expert. Do not ask them to go through the incident or talk about the issue, because you're not qualified to deal with it. And that's a big thing to take on yourself. So it's exactly what Siobhan has said. I don't know, who's Michelle?
Who's Michelle?
Oh, Michelle O'Neill. No, God, no. But
in the government for so long.
And I think she'd be a great First Minister. It's what Siobhan has said. It's what the professor has said. I'm not going to get out of it, am I? It is about the right sort of training, but everyone being comfortable about having the conversations.
I am going to take
this last question. Thank you, everybody. And Kula, I wish you good luck in your new endeavor. And my point is just about consideration for people from minority communities. And as you are leaving your post there, maybe it will be helpful as well if you can just put that to-do list of the new commissioner.
100%. Thank you for that. It's a really good question, and we're seeing it in a lot of schools at the moment. Schools that are offering support to newcomer children, particularly children seeking asylum, children from families seeking asylum, because of the trauma they've already been through. So it's, particularly we know from our refugee children that a lot of them will have had trauma in fleeing, and so we need our school-based programmes in the first instance to be able to meet those children and young people's needs, and we need to be able to support young people. But yes, you're right. I will put it on the list, I promise, for the new commissioner. God love them. But it's such an important, and we're already hearing about it from schools, and we're also hearing about it from the services that are supporting families in the contingency accommodation. But also, so as a young person for whom English wasn't my first language, I didn't have any English till I was 5, we need to be able to learn how to speak to children in their first language, particularly. So we've still got a long way to go in Northern Ireland, but we absolutely need to talk to children in the actual language that they feel the most comfortable with disclosing to us. But there's a lot of work to be done, and let's not forget, we do have hundreds of newcomer children who have experienced some of the most horrific trauma you could ever imagine, and it is our responsibility to support them and their families to heal.
Thank you. I just want, before I bring the panel to a complete close, I would like just to say, I don't know, is this your last public engagement?
It's my last proper speech,
yeah. So I think Cuala deserves a massive, massive round of applause. We will certainly miss having you at the end of the phone in that with that hat on, but we'll get you back on about other things. I'm going to leave it to Professor Siobhan O'Neill to close the conference, but panellists, thank you so much.
Okay, thank you so much, Tara and everybody, and thanks for the questions for the panel. So it's up to me now to close the conference. Can I thank all of you who stayed with us to this point? It's really amazing and remarkable that we've retained the numbers that we have, because it's been a long day and there's a lot of news today and there's a lot of stuff happening. So I think it really speaks to the quality of the presentations, that you're here and that you're engaged and that you still have the energy for this. I'm highlighting again that this has been an intense day for many of you, even the staff who are working around here. You know, there's been a lot. There's been a lot of suffering and pain. So do be very gentle on yourselves and try and do something nice if you can, and try and think about things that we can take away that give us hope. You know, really, that's what it is that I'm trying to emphasise. And there's so much to be hopeful for, and we've seen that in the presentations today. So just remind yourself of that, a bit of self-compassion, self-care for the rest of the day and tomorrow and the coming days as you process what you've heard today and what's been said and how it relates to your own experiences and the people you care for. And thank you so much. I know so many of you are on the ground doing the heavy lifting, providing services in the most difficult of circumstances, and facing further cuts, surges in the numbers of people coming forward. And a lot of the stuff that we're talking about today honestly does feel like a million miles away to what's happening on the ground, and that's really difficult, and it's really difficult for me as well, and I can feel that too. But there's so much we can do, and every step forward is a step forward. So thanks for what you're doing, and I reaffirm my commitment to keep working to try and make things better and to get the funding for the strategies and plans that we need, and funding for your services so that you can continue to do the good work. So now I have a load of thank yous. Firstly, the MAC. I think it's been a brilliant venue for the conference. It's been really nice. The food has been really good, and I hope you're comfortable, and the toilet facilities and everything's been grand, and plenty of water. So thanks so much to the MAC for doing this for us and with us, and for adhering to the sensitive nature of the conference, and the way that we wanted this presented. So thank you for that. Thank you to all of the speakers. I kind of selected speakers that I wanted to hear, so I'm super excited. And these people really are the best in the business, but they're also really good people who really want to make a difference. And I think Nav came in this morning and he said this was his 4th presentation, like in just the space of a weekend, and that's the kind of level that we're dealing with here. They're running about. Ella had meetings this morning, so I am so grateful that you gave of your time. You came to Belfast, Hazel's there as well. You came to Belfast to give us your wisdom. So we assure you it'll not be lost, and what you've said will be absorbed. But I'm really, really grateful. Thank you to the panellists. Thank you to the young people who've participated as well. It does take a lot. You're exposing yourself in a way. You're very vulnerable when you're talking about your own stuff. So we are privileged to hear this, and we recognise that, and we thank you for that, and we hope we'll do it justice, as we go forward and try and get the changes to make things better. Thank you to Tara. Tara, I don't know where you are. You've been brilliant too. You've handled everything so sensitively. Again, we need that guidance, that leadership, somebody keeping us right, but being tuned in to the energy of the room and who's looking to speak and all that stuff, and managing so much, and you were just brilliant. So thanks a billion. We're glad that you stuck with us through all the changes too. And thank you. My final thank you goes to my own team who are behind the scenes, and they're brilliant, and they rarely get credit for the stuff that I do, but really they keep me right, and they give me the energy to do what I do, and they manage things for me. So I've got Peter and Neil, and Hazel's been in the background as well. But Nicole, where's Nicole? My new researcher, she's around there too, and she's been doing great stuff with children and young people. And most of all, though, Kifa has been just brilliant. She's been the captain of the ship, keeping everybody right, and you can see her running about, and she's put so much into this. So I just want to say publicly, Kifa, I'm really, really grateful for all the work and the effort here. So thank you again to everybody who's been involved. Thank you for those of you who are attending. Thank you for coming and showing up and sticking with us, and thank you for the work that you're going to do now in the communities, and for the stuff that you're going to bring back to move everything forward. And thank you for really creating the hope and bringing the hope to the people that need it out in Northern Ireland. So safe home, and you know where I am if you need to connect with me. I'm on social media. There's a website as well. Just give us a ping, and if there's anything you want me to address as mental health champion, I'll do my best to try and get that sorted. Okay, thank you.